어. 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 어.
하나, 둘, 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 둘. 아, 들어오는 거 같아.
어. 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 안 들어와. 어. 어.
아, 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 아,
허, 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 허. 허, 허, 허. 하나, 둘, 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 둘. 한번 바꿔봐 그럼. 허, 허, 허. 아니 그럼 하나 허, 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 허. 하나, 둘, 둘, 하나, 둘, 하나, 둘, 하나, 둘, 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 하나, 둘, 하나, 둘, 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 하나, 둘, 셋, 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 하나, 둘, 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 하나, 둘, 하나, 둘, 둘, 예. 허, 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 둘, 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 둘. 이렇게 하면 되잖아.
Hello?
짚 라인을 찾아서 가야겠지 그럼 한번 보자.
Oh, wait. Hello? Can you hear me? Hello? Hello? Speaker? Testing? I think we have to get everyone. Can you hear it? Can you hear? Hello, everyone. We're good. Hello, my name is Mary Choi. I'm the president of the Korean American Medical Association and a professor of medicine at Weill Cornell Medicine. It is my distinct honor to welcome everyone to the 46th Annual Scientific Convention of the Korean American Medical Association. I wish to extend the warmest greetings to everyone joining us today from the United States and from South Korea. On behalf of the Executive Committee and the Board of Directors of the Korean American Medical Association, we salute you, and we're very much looking forward to your participation over the next 3 days. I'm so excited that we're finally holding this very special international hybrid meeting, bringing together speakers from the US participating remotely and on-site participants from Korea at the Sheila Seoul. As we're only too aware, the whole world had to endure the most unprecedented, challenging times. The COVID-19 pandemic has affected communities around the world. It has touched every one of us in one way or another, and the pandemic has brought on much human suffering and loss. However, I'm very proud to know that we stood strong and courageously fought against this coronavirus. Hopefully we're emerging from the pandemic, but many of you worked tirelessly on the front lines and courageously provided healthcare in the most selfless way. The pandemic has certainly drawn into sharp focus what it really means to be a physician and the importance of healthcare. As many of you know, the COVID-19 pandemic has disrupted our plans to hold the annual KAMA convention last year, and then the rescheduled convention this past July. So I am truly delighted and grateful that we are finally able to hold this long-awaited convention. The theme of this year's convention, 2021 Vision for Diversity, Innovation, Cure, reflects our overall aim to promote diversity, particularly for women in medicine, and increase international collaboration among physicians in the US and South Korea in order to drive innovation and find new cures. We have an exceptional educational and interactive conference planned. It is very fitting that the opening plenary lectures will be delivered by 2 prominent infectious disease experts, Dr. Anthony Fauci, the director of the National Institute of Allergy and Infectious Disease, who is also the chief medical advisor to the President of the United States, will speak on COVID-19, lessons learned, and the remaining challenges. We also have Dr. Jerome King, the Director General of the International Vaccine Institute, and he will speak on vaccines for emerging infectious disease with a focus on the SARS-CoV-2 outbreak and COVID-19 vaccine development. Dr. Susan Bailey, our immediate past president of the American Medical Association, is our keynote speaker. And along with her, Dr. Howard Koh, the 14th Assistant Secretary for Health for the United States Department of Health and Human Services, will deliver keynote addresses. Dr. Bailey will speak on the topic of closing the gender divide in medicine, and Dr. Koh will speak on the role of public health and diversity, particularly as it pertains to Korean Americans. In addition, our scientific program features many outstanding speakers from the US and South Korea, covering a breadth of topics, including the Leaders Forum with deans and hospital presidents, wherein we will learn from our leaders the current directions in medical education and hospital operation. There will be a special session on women in medicine, with panel discussion among women physicians in both the US and Korea. Last year was the 30th anniversary of the Hoam Prize, a most honorific award recognizing outstanding individuals of Korean descent and heritage who have furthered the welfare of humanity through distinguished accomplishments in areas including medicine, and we will hear from 3 Hoam Prize in Medicine laureates who are, by the way, also National Academy of Medicine members and preeminent physician scientists, renowned for their seminal contribution in scientific research. We will also learn about entrepreneurship in healthcare from the founder of CityMD. Through collaboration with the Korean Medical Association, there'll be a focus session on hospital medicine and advancement made through strong collaboration between the US and Korea. And finally, I want to bring your attention to special sessions planned that focus on topic of interest for our medical students and training physicians, residents, and fellows. The all-important topic of well-being and mental health, and also a research abstract competition was conducted leading up to this convention. We will have abstract posters and award presentations from this talented group. I have to say, whenever I interact with our students and residents and fellows, I'm encouraged that our outlook is bright as they represent the future. They are the eventual leaders of our Korean American medical community and Korean medical community. So having their involvement here and in KAMA and mentoring them are so important. And of course, it's a passion of mine. And I want to remind you that there are many additional outstanding sessions over the next 3 days. We're honored and grateful to have you be a part of this important event. Allow me to express my sincere thanks for your participation and support of KAMA. I hope you will attend as many of the sessions as possible and learn and enjoy and be inspired as I know I will be. So thank you so much for your patience and your attention. And now we'll hear from our very distinguished guests who will deliver what we say in Korean, chuksa, which means congratulatory remarks. And I'm very pleased to say that the first will be Dr. Susan Bailey, who just completed her term as the AMA president in June of this year. And we're also very honored that Dr. Bailey will be delivering her keynote lecture tomorrow, so please stay tuned. Dr. Bailey?
Innovation and cures perfectly represents the values of organized medicine today and into the future. We've been reminded throughout the pandemic of the critical role of medical organizations as an ally for physicians, for patients, for our healthcare community, and as leading advocates for science at a time of so much mistrust and skepticism for medicine. But in a crisis like COVID-19, physicians need more than just our support. They need organized medicine's power and influence to accomplish what we cannot possibly do as individuals, to make our jobs a little easier, to remove the daily frustrations that interfere with patient care, to create an environment that promotes greater diversity and inclusion for physicians from all backgrounds, to spearhead innovation in digital technology so that it improves instead of detracts from patient care. and to make our global health systems more accessible and more equitable for all people. Only organized medicine can do this work. Only we can deliver what physicians and patients most need in a crisis. Forums like this one give us the opportunities to learn from one another, to share ideas and common concerns, and to unify our approach, to borrow the AMA's mission, to promote the art and science of medicine and the betterment of public health. We've been reminded over the last 2 years just how urgent this work is and how all of us in organized medicine contribute to this common cause. I congratulate CAMA on this wonderful convention, and I thank you so much for the opportunity to be a part of it.
Thank you, Dr. Bailey. Thank you so much. Next, I invite Dr. Pil-Soo Lee to the podium. Dr. Lee is the president of the Korean Medical Association, and I also would like to take this opportunity to express our sincerest thanks to Dr. Lee and the KMA staff, without whose help truly it would not have been possible for the KAMA executive team to travel to Seoul for this convention. So thank you very much.
존경하는 재미 한인의사협회 메리츠 회장님, 그리고 이곳에 자리하신 내외빈 여러분 반갑습니다. 제41대 대한의사협회장 이필수 인사드립니다. 대한민국 13만 의사를 대신하여 서울에서 개최되는 제46차 재미 한인의사협회 연례 학술대회에 참여하신 여러분들을 진심으로 환영합니다. 아울러 코로나19로 쉽지 않은 여건 속에서도 이번 행사 준비를 위해 노고를 아끼지 않으신 메리츠 회장님을 비롯한 관계자 여러분께 깊은 존경과 감사의 말씀을 드립니다. 지난 1974년 비영리단체로 시작한 재미 한인의사협회는 해마다 정기 학술대회를 열어 미국 전역에서 활발하게 활동하고 계시는 한인 의사, 연수생, 의대생 여러분들이 다양한 의학 지식과 학술 정보를 교류하고 회원들 간 친밀하게 소통하여 인적 네트워크를 넓힐 수 있는 기회를 마련해 주시고 있습니다. 이번 학술대회 역시 그간 축적된 경험을 바탕으로 다채롭고 내실 있는 프로그램들로 가득 차 있는 걸로 알고 있습니다. 2021 비전 포 다이버시티 이노베이션 큐어를 주제로 새로운 치료 방법을 모색하고 여성의학 분야의 다양성을 증진하기 위해 마련된 이번 행사에는 다양한 연자들께서 자리를 빛내주고 있어서 더욱 기대가 되고 있습니다. 존경하는 재미 한인의사협회 회원 여러분, 우리 의료인들이 코로나19 진료와 방역의 최일선에서 국민의 건강과 생명을 지키기 위해 고군분투한 지도 벌써 2년이 되어가고 있습니다. 코로나19 장기화 속에서 우리 의료인들은 지금 이 순간에도 목숨을 걸고 국민의 건강과 생명을 지키기 위해서 최선을 다해가고 있습니다. 최근에는 코로나19 새 변이인 오미크론이 세계 각국으로 펴지면서 위기감이 더욱 증폭되고 있습니다. 변이와 겨울철 확진자 급증 등에 철저히 대비하기 위해서는 의료 전문가의 경험과 지식을 바탕으로 의견을 내어 올바른 정책에 저희 의료 전문가들의 의견이 반영될 수 있어야 할 것이라고 생각합니다. 저희 대한의사협회에서는 어려운 시국에도 굴하지 않고 대한민국뿐 아니라 세계가 코로나19 팬데믹을 극복하고 일상을 회복할 수 있도록 끊임없는 목소리를 낼 것입니다. 존경하는 재미 한인의사협회 회원 여러분, 의학적 경험과 정보는 나라마다 조금씩 다를 것입니다. 코로나19 종식이 가까워지기 위해서는 세계 의료인들의 협력과 교류가 매우 중요하다고 생각합니다. 그러한 협력과 교류의 장이 오늘과 같은 학술대회라고 생각합니다. 코로나19로 전 세계가 어지러운 상황이고 어려운 상황이지만 우리 의료인들이 최신 의학 정보와 지식을 폭넓게 탐구하고 교류하는 데 더욱 매진하여 지금의 위기를 극복하는 해법을 찾아낼 수 있기를 희망합니다. 오늘 학술대회가 성공적으로 치러지기를 바라며 이번 기회로 다양한 의학적 발전 방안들이 논의되고 한층 더 성장하는 기반이 마련되는 계기가 될 것인 것은 물론 한인 의료인과 국내 의료인 간의 의학 교류의 장이 될 수 있기를 기원합니다. 감사합니다.
Thank you, President Lee. Next, congratulatory remarks will be Dr. Yeon-Soo Kim, the president of the Korea International Medical Association, or KIMA, and the president and CEO of Seoul National University Hospital, and a fellow nephrologist.
Thank you. Good morning, and actually good afternoon or good evening. Dear colleagues, I'm Yeon-Soo Kim, the president of Seoul National University Hospital and Korea International Medical Association. First of all, I really congratulate the already 46th Scientific Convention of KAMA this year to discuss the sustainable growth and future, even though the pandemic of COVID-19 makes limited travels. Around the world, interest and recognition for Korean medicine care are currently increased by the creative response to COVID-19 and the voluntary compliance with quarantine rule. At this time, the scientific convention is held in Korea. I think it can be a good opportunity to strengthen international cooperation between Korean physicians. The Korea International Medical Association, KIMA, is also very interested in international cooperation and interaction. The primary function of KIMA includes promotion of Korea's healthcare to the international communities and fostering the safe and reliable healthcare infrastructure in Korea. Also, according to the changes in the post-COVID-19 environment, KIMA will make every effort to promote the excellence of Korea medical care and representing medical institutions in Korea to the world. We are currently living in COVID-19, and the social distancing becomes normal life. But in the future, we'll make this crisis as an opportunity to move forward to find a new way of medical field, while considering the most appropriate medical care for COVID-19. Today, at this conference, under the theme of 2021 Vision for Diversity, Innovation, Cure, leads the innovation regardless of the distance between Korea and the United States, and becomes a venue for active communication and discussion about diversity. After COVID-19, I hope that it will revitalize the international cooperation between Korea and American physicians and the stars for sustainable growth and future-oriented development. Thank you very much.
Thank you, President Kim. Next, Dr. Seok-Won Yoon, please come to the podium. Dr. Yoon is the president of Korean Medical Women's Association.
안녕하십니까. 한국여자의사회장 윤석안입니다. 오늘 제46차 카마 연례 학술대회에 초대해 주셔서 대단히 영광스럽게 생각합니다. 큰 행사를 준비해 주신 메리체 회장님과 학술위원장이신 제니퍼 리 선생님, 그리고 모든 카마 관계자분께 존경과 감사 인사를 드립니다. 지속되는 코비드-19 상황에 작년 2020년 7월로 예정되어 있던 제46차 카마 연례 학술대회가 늦어졌지만 올해 아슬아슬하지만 다행히 개최되게 됨을 다행스럽게 여기며 성황을 이루시기를 기원합니다. 한국여자의사회도 올해 8월 20일, 21일 양일에 걸쳐서 세계여자의사회 서태평양 지역 국제학술대회를 버추얼 컨퍼런스로 개최하여 8개국 세계여자의사회의 임원들을 합하면 18개국 420여 명이 참가하여 대회를 성공적으로 개최한 바 있습니다. 제46차 카마 연례학술대회 프로그램을 보니 카마의 40여 년 넘은 역사만큼 훌륭한 연자분들이 대거 참가하여 다양한 주제의 좋은 강의로 구성하신 것 같아서 큰 기대를 안고 이 자리에 왔습니다. 그동안 카마가 한미 양국 의료계의 교류 증진에 큰 역할을 해오셨던 것처럼 오늘 이 대회를 통해서 우리 한국여자의사회와 카마가 서로 긴밀히 협력하는 관계로 발전하는 계기가 되길 바랍니다. 다시 한번 제46차 카마 연례학술대회 개최를 축하드리며 카마의 무궁한 발전을 기원합니다. 고맙습니다. 새해 복 많이 받으십시오.
Thank you, President Yoon. And our final congratulatory remarks will be by Dr. Young-Ho Jung. Please come to the podium. Dr. Jung is the president of the Korean Hospital Association.
안녕하십니까. 대한병원협회 회장 정용호입니다. 재미 한인의사협회의 제46회 연례 학술대회 개최를 진심으로 축하드립니다. 행사를 마련하신 최마리 회장님이야 관계자 여러분들의 노고에도 감사를 드립니다. 코로나19의 어려운 상황 속에서도 글로벌 보건의료 서비스 동향과 정보를 공유하기 위해서 소중한 시간을 마련하신 오늘의 행사는 큰 의미를 갖는다고 생각을 합니다. 그것은 오늘의 행사가 질병의 예방과 치료를 위한 의학적 지식을 함께 나누고 4차 산업혁명 시대의 로봇과 디지털 의료 서비스 시스템을 활용하여 변화하는 의료 패러다임을 짚어볼 수 있도록 프로그램을 구성하고 있기 때문입니다. 혁신적 변화와 치료 방법을 보여주는 최신 정보들을 함께하며 글로벌 헬스케어의 방향성을 점검해보는 좋은 기회가 될 것이라고 기대를 합니다. 한국과 미국에 동시에 생중계되는 오늘의 학술대회는 그야말로 지구촌이라는 말이 실감나는 행사인 것 같습니다. 코로나19 이후 비대면이 활성화되다 보니 몸은 떨어져 있어도 항상 곁에서 함께하는 듯한 느낌이 있는 것도 사실입니다. 우리는 지난 2년여간 코로나19로 잠시 멈춤의 시기도 있었고 비대면으로 인한 원격 의료 등 변화하는 의료 이용의 모습도 경험했습니다. ICT 기술을 활용한 변화와 혁신은 미래 의료의 한 축으로 자리 잡을 것으로 예견되는 상황입니다. 의료의 패러다임이 바뀌어 가고 있는 만큼 미래 헬스케어 분야에 있어서도 재미 한인의사협회가 선도해서 올바른 방향 제시를 해 주실 것이라고 기대를 합니다. 최근 또 다른 변이 바이러스 출현으로 다시금 전 세계가 불안과 긴장 속에 있습니다. 그러나 우리는 감염병에 대해 항상 슬기롭게 극복해내고 일상으로 복귀해 왔기 때문에 이 또한 슬기롭게 극복할 것으로 믿습니다. 2021년도 얼마 남지 않는 기간에도 항상 건강관리에 유의하시고 행운이 함께 하시기를 기원합니다. 감사합니다.
Thank you, President Jung. So I sincerely hope that everyone will enjoy today's conference and the next 2 days of the convention. And again, thank you for your participation. With that, I'll turn the podium over to one of our executive committee member, Dr. Cecilia Yoon.
Thank you. So I will be moderating the first section, the first topic on global health. It will be separated into 2 sessions. The first will be a plenary session with 2 speakers, 2 lecturers, followed by a question and answer session. So if you can please upload any questions on the YouTube chat, we'll try to get to them as much as possible. So I'm going to have Dr. Mary Choi, President of KAMA, give the introductions for the 2 plenary speakers for this first session. Thank you.
So, hi. It is my great honor to introduce our first plenary speaker, Dr. Anthony Fauci, who probably doesn't require a lot of introduction, but he is our leading expert on infectious diseases, bar none, we think. Dr. Fauci has directed the United States National Institute of Allergy and Infectious Diseases for the past 37 years, since his first appointment as its director in 1984. He has served through 7 U.S. presidential administrations and is currently the chief medical advisor to President Biden. A lesser-known fact about Dr. Fauci is that I have a connection with him, as he's a graduate of Weill Cornell Medical College, my institution. And I've had the honor of meeting Dr. Fauci and his lovely wife, Dr. Christine Grady, at our alumni events on numerous occasions. Dr. Fauci also completed his internal medicine residency and was a chief resident at our hospital, the New York Presbyterian Weill Cornell Medical Center. Dr. Fauci has served as a guiding shepherd through a long procession of viral epidemics throughout his career and has been the beacon of light during this pandemic. And Dr. Fauci will speak today on COVID-19, lessons learned, and remaining challenges. Dr. Fauci.
Warm greetings. My name is Tony Fauci, and I am pleased to speak to you at the Korean American Medical Association Annual Scientific Convention. As you can see from this first slide, I'm going to be discussing the lessons that we've learned and the remaining challenges in this era of COVID-19. I'm dividing this talk up into 6 components, and I'll very briefly highlight the salient features of each. Starting off with the epidemiology. As we all know, we are in the middle of the most extraordinary outbreak of a respiratory disease in the past 100 years, with already over 260 million cases globally and 5.3 million deaths, which is likely a substantial underestimation of what the actual numbers are. If you look in the United States at the pattern of the various surges that we've seen from very early in 2020. You can see that we've had different surges, and we are now coming first down from a surge that we had during the summer, but now a spike back up as we're entering into the winter months. Note the comparison between the cases and the numbers in the United States compared to South Korea, which as a country has done much better than the United States when you look at the number of cases per million people. The virology is now well studied. This is a beta coronavirus, an RNA virus with a large genome with 4 structural proteins, the most important of which is the S or spike protein, particularly with its receptor binding domain, which binds to the ACE2 receptor on cells in the upper and lower airway, as well as in the GI tract and certain cardiovascular tissue. Again, the transmission, which was somewhat unclear in the beginning of the outbreak, is really quite clear right now. It's by exposure to infectious respiratory fluids, not only fine respiratory droplets, but as we came to learn and to know, also by the inhalation of aerosol particles, which are deposited in the mucous membranes of the mouth, the nose, or the eyes. Of note, transmission is much less common through contact with contaminated surfaces, and the risk is greatest in places with poor ventilation, such as during behaviors such as exercise, hence the increased risk in gymnasiums, as well as singing, such as the risk in choirs where people sing in church. Some very important oddities and perhaps even unique aspects of this particular virus is that at least 1/3 and as high as 40% of people who are infected with SARS-CoV-2 never develop any symptoms. And in fact, with regard to the transmission, anywhere between 50 and 60% of all the transmissions result from someone who does not have symptoms, either someone who never will have symptoms or someone who's in the pre-symptomatic stage, which makes it extremely difficult to do the kind of tracing that is generally done with purely symptomatic respiratory illnesses. The clinical course is protean. As I mentioned, about 1/3 or so of people never develop any symptoms. Those who do, the clinical presentation is very similar to a flu-like syndrome, which is going to make it much more difficult when we get into the full-blown flu season of the upcoming winter. One relatively unique aspect of this particular infection is the peculiar loss of smell and taste which generally precedes the onset of respiratory symptoms and can linger for a significant period of time following the clearance of the acute infection. Of those who do get symptoms, about 80% of them are mild to moderate, and anywhere from 15 to 20% are either severe or critical, leading to a variable case fatality rate of anywhere but 2.3 up to 20% in people who require mechanical ventilation. The people who are at increased risk for severe illness are older adults, particularly those over 75 years old, as well as people of any age who have certain underlying conditions, such as obesity, hypertension, diabetes, chronic obstructive pulmonary disease, and a variety of other underlying comorbidities. The manifestations of severe COVID-19 are dominated by respiratory symptoms, including the acute respiratory distress syndrome. However, as our experience over the last 2 years has accumulated, we are seeing now neurological disorders, cardiac dysfunction, acute kidney injury, and very unusual states like hypercoagulability with microthrombi in various organ systems, as well as, particularly in late disease, a hyperinflammatory syndrome, which is characterized by an aberrant immune and inflammatory response. Children can get a multi-system inflammatory syndrome, which is strikingly similar in many respects to Kawasaki syndrome. There is a situation called post-COVID-19 conditions that have to be looked at in two separate buckets. One is identifiable residual organ system dysfunction that can be directly explainable by prior organ system damage. For example, if you have severe involvement of pulmonary infiltrates, you can expect that even after clearance of the acute infection, you will have residual pulmonary function abnormalities. However, there's also in about anywhere from 10% to as high as 40+% of people have the persistence over weeks and sometimes months of signs and symptoms that are not completely explainable by a readily apparent pathogenic process. This is referred to as long COVID. These are some of the protean manifestations of post-COVID conditions. However, they seem to be dominated by profound fatigue, particularly following activity, sleep abnormalities, shortness of breath, mood disturbances, as well as a variety of other signs and symptoms, including what some refer to as brain fog or an inability to focus or concentrate. There have been significant advances made in therapeutics, which are directed in two specific areas. One is to target the virus itself. And in this regard, we already have FDA-approved one intravenously administered drug called remdesivir, which has shown the capability of diminish the likelihood of progression of disease. We also have a number of monoclonal antibodies that, if given early in the course of infection, have shown to prevent the progression leading to hospitalization and death, and in some cases as pre-exposure prophylaxis. Late in the course of disease, which is often dominated by a hyperinflammatory or aberrant immunological situation, a simple drug such as dexamethasone is recommended for people who require oxygen and other supplementary pulmonary function capabilities. Then you have other monoclonal antibodies like tocilizumab and baricitinib, which are against certain components of the inflammatory response, such as JAK kinase and IL-6. Most recently, a lot of effort has been put into identifying the vulnerable targets on the SARS-CoV-2 replication cycle and to either screen for or proactively design drugs to inhibit these vulnerable targets. This is schematically shown on this slide, with the large circle being a target cell and the smaller circles being the SARS-CoV-2 virus. And very similar to what we had done decades ago with antiretroviral drugs for HIV, one can target vulnerable components of the cycle, such as polymerase, protease, and various components of the entry mechanism, and design inhibitors of these processes. For an example, one drug called Paxlovid, which is a protease inhibitor, which is given with ritonavir, was shown in a clinical trial to result in a close to 90% reduction in hospitalization or death if given in the first 3 to 5 days of recognizable symptoms. And in that study, there were 10 deaths in the placebo arm and no deaths in the treatment arm. Another drug, molnupiravir by Merck, has less dramatic effect with a 30% decrease in hospitalizations and deaths, again in a placebo-controlled trial involving more than 1,000 individuals. Now let's talk about vaccines. There truly is one outstanding success story thus far in the response to COVID-19, and that is the development of safe and highly effective vaccines in record time from the time that the virus was recognized in January of 2020. 11 months later, we had a highly effective and safe vaccines going into the arms of individuals in December of 2020, a feat completely unparalleled in the history of vaccinology. And for that, the development of vaccines for SARS-CoV-2 earned the Scientific Breakthrough of the Year for Science magazine. And here's a list of the 3 platforms, mRNA, adenovirus vector, and recombinant protein, all using the very effective stabilized prefusion immunogen of the spike protein developed by individuals at the NIAID Vaccine Research Center. And also you see that we have 6 companies now involved in the development of these vaccines. One of them, the BioNTech, has already received a full approval by the FDA. Moderna and J&J have emergency use authorizations, and the other candidates are in line for presenting their data to the FDA. How do we know these vaccines work? Very clear efficacy in clinical trials, and I'll just give you some examples among many of the vaccines that were tested here in the United States. As you could see from these New England Journal of Medicine papers, the Pfizer-BioNTech and the Moderna vaccines, which involved tens of thousands of people in a placebo-controlled trial, showed an efficacy of 95 and 94% respectively. The J&J vaccine, which is the adenovector vaccine, was tested in multiple countries and showed a 72% efficacy for symptomatic disease in the United States, but also protected against the variant, which at that time was a beta variant in South Africa. The effectiveness of these vaccines would then clearly be shown in the real world. And I'll give you one example of that, but there are many, many examples. If you compare a vaccinated with an unvaccinated person the risk of infection was reduced fivefold, the risk of hospitalization by more than tenfold, and the risk of death by more than tenfold in a vaccinated person compared to an unvaccinated person. Now, as we know, all of this has been impacted significantly by the evolution of SARS-CoV-2 variants. And here's the list of several of the variants that we've had to deal with. The one that has dominated the United States and, in fact, the world for the last several months since the beginning of the summer is the Delta variant, which now accounts for more than 99.9% of all the isolates that are sequenced in this country. And now about 150 countries throughout the world have a high level of Delta variant. It has assumed this dominance because its transmissibility is highly effective, at least 2 times greater than the Alpha variant that previously dominated this country. And when you measure, viral loads are seen up to 1,000 times higher in the nasopharynx compared to Alpha variants. And now, just recently, we see we will be dealing with the Omicron variant, which originated first and was first reported in Botswana and then isolated in South Africa. The reason this is so concerning is that there are about 50 mutations in this virus, than more so than any of the other variants we've seen. About 30 of these are in the spike protein, and about 10 or more are in the receptor binding domain. These numbers change by the hour, but from the time I made this slide, there were close to 500 confirmed cases and thousands of probable cases from up to 40 countries. As I mentioned, it's referred to as the Omicron variant by the WHO. And the 3 big questions, which we will answer within the next week or 2 or 3, is, does it have a transmission advantage? The confirmation of the mutation suggests that in fact might be more efficient in transmissibility. We will have to wait and see, but early suggestions in South Africa indicates that it is more transmissible than Delta. We will have to see how this spells out in a population in the United States, which is much more highly vaccinated than South Africa. The next will be, will there be a diminution in the vaccine-induced antibody capability of blocking? Again, time will tell as we assay the sera of vaccinated people against the virus when it's put into a form, either as whole virus or a pseudovirus, where we can assay it for the impact of this virus on neutralizing antibodies. And then the big question is, what is the level of disease severity in people who are infected with the Omicron variant? Let's take a look at why we are in a somewhat significant time in our course, because we're seeing the waning of immunity. If you look at this graph, the orange is Moderna, the gray is Pfizer, and the blue is Janssen. In each of these, the efficacy of a vaccination, although these vaccines, as I mentioned, were 95% effective, the efficacy wanes over a period of months, which has led us now to strongly recommend booster shots for people who are fully vaccinated. We know they work. The Israelis, who are temporarily ahead of us with their boosters, show that you lower the rate of confirmed infection by a factor of more than 11, and the rate of severe disease by a factor of more than 19 in the boosted group compared to the non-boosted group. These are some slides, this one from Israel, showing the cumulative incidence of infection leading to hospitalization, severe disease, and death in those who've received 2 doses, as shown in the red and pink part of this curve, versus those who received a 3rd booster dose, as shown by the bluish green line on the bottom. That's not only in Israel, because if you look at Brazil, South Africa, and the United States, and you do an efficacy analysis against symptomatic infection in the boosted group compared to the unboosted, it was 96% effective. And here's an example from that study where those who received only 2 doses are shown in the red boxes, and those who received the booster dose are shown in the blue when you measure the cumulative incidence of occurrence of infection. For that reason, the CDC has recently expanded its booster recommendations to recommend boosters for everyone who has received a primary immunization 6 months or more ago, if it were mRNA, and 2 months or more if they received the J&J. Let me close by making a statement of why, when we talk about boosters, it's so important to emphasize that we have a responsibility, and I believe a moral responsibility, to make sure we provide doses of vaccine to the lower middle income countries at the same time as we are boosting our own population. And in this regard, the United States has already done more than all other countries of the world combined by the donation of hundreds of millions of doses to low and middle income countries, including the plan to get to 1.2 billion doses before the middle of next year. So we want to make sure we realize how important it is to make sure that low and middle income countries have access to these life-saving vaccines. And I'll close with this last slide, which really schematically in a cartoon way really summarizes what I've been saying, that we are dealing with an extraordinary virus that evolves into different variants. We have a very, very powerful tool against that virus, and that is vaccines. And that is why it is so important that we get as many people vaccinated as quickly as we possibly can. And for those who've been fully vaccinated, we get them boosted. Only then will we clearly win the race against this formidable foe, the SARS-CoV-2. Thank you.
Thank you. So I'm very pleased to introduce our next plenary speaker, Dr. Jerome Kim. Dr. Kim is currently the Director General of the International Vaccine Institute. He received his MD from Yale University School of Medicine and completed his training in medicine at Duke University Medical Center, where I actually overlapped with him as medicine resident. Dr. Kim subsequently completed a fellowship in infectious diseases at Duke, and he's an international expert on the evaluation and development of vaccines and currently directs the International Vaccine Institute here in Seoul since 2015. IVI is a Seoul-based nonprofit international organization devoted to research in vaccine development and delivery for the developing world. Dr. Kim is also an adjunct professor of the Department of Medicine at Uniformed Services University and the Graduate School of Public Health of Yonsei University. He has authored over 300 publications, and today Dr. Kim will speak to us on vaccines for emerging infectious diseases, the SARS-CoV-2, COVID-19 outbreak, and vaccine development. Dr. Kim, welcome.
Thank you very much, Dr. Choi. and it's a pleasure to see you again after so many years. The thing about residency and internship and residency, actually I spent part of my internship with the other Dr. Choi, is that it creates these bonds that link you together and common suffering. But I'm going to focus actually today on vaccine development, and although I use the word challenges, I'll use it in a slightly different way from Dr. Fauci, who has been a mentor, a friend, and an advisor and supporter throughout my career. So it's always a difficult thing. It's both an honor and a very, very difficult thing to follow him in a talk. It's really a pleasure to be here at the KAMA Scientific session. Why? Because Korea has and is hoping in the future to make further contributions to vaccine development globally. And IVI is proud to be a partner with the Korean government as well as other governments around the world in the effort to make fair and equitable access to vaccines a reality. So these are disclosures. So I'm going to start from a slightly different place, again, than Dr. Fauci. Let's talk about where the world is in vaccination. And you can see in this chart from Our World in Data, in green are those countries that have at least 100% of use of vaccines. So the number of doses divided by the population is a ratio of at least 1 or greater. And I think I want to point out to you that Sub-Saharan Africa is yellow. And so 54.9% of the world has received at least 1 dose. 8 billion doses have been given to date. Still, 6.2% of people in low-income countries have received a dose, which means that roughly 94% of people in those countries have not received anything. And as of December 5th, there were 266 million infections, 5.3 million deaths from COVID, and as Dr. Fauci pointed out, this is probably an underestimate. And at many levels, the policies that we've put into place, even with vaccines, have had difficulty in controlling COVID-19. This is from a German magazine, from the New York Times, from BBC News, and you can see the Worldometer Coronavirus Index of Daily Cases showing again the emergence of yet another wave. So challenge number 1. IVI likes to think that we move from need to impact. In this case, challenge number 1, and Dr. Fauci has already pointed this out, we went from the definition of need, the sequencing of the SARS-CoV-2 coronavirus, to safety and efficacy in less than 12 months. This is a partial list of vaccines that were initial contenders for early vaccines, and actually many of them came out in 2020. You can see the efficacy listed in red. The efficacy varies from 50% for Sinovac to 95% for Pfizer. And because IVI works internationally, we're not only going to concentrate on those vaccines that have been approved by stringent regulatory authorities, that is the US FDA or the EMA, but we will look at vaccines from all over the world. This is actually broken down into neutralizing antibody titers. So in gray are those under 100. In yellow, those that are between 100 and 500. And in green, those that are above 1,000. Now, of course, efficacy didn't necessarily correlate with neutralizing antibody, and we'll go into that in a little bit. I think one of the most important things about this list, though, is innovation. 8 vaccines have received WHO emergency use listing, which means that they can be purchased by UN agencies for use around the world. 28 vaccines, so even greater than the number on this list, are approved by at least one national regulatory authority. And we have some very amazing new platforms. mRNA. There had never been an mRNA vaccine. We now have 2, maybe soon more. Adenoviral vectors. Again, Janssen had an early vector, but it wasn't highly used. Now we have chimpanzee adenovirus and Ad26 vaccines that are emergency use listed. DNA vaccines. So the Indian company Zydus Cadila actually has an approved DNA vaccine. And of course, the new adjuvants. That's actually shown with the red arrow from Bharat. It's a whole inactivated virus vaccine, a very old technology. But the inclusion of this additional adjuvant in midazoquinoline appeared to increase the efficacy of the vaccine. So that was the first wave. And now we have what have been defined as waves 1A and wave 2, or maybe wave 2 and wave 3. And those are vaccines where efficacy is reported this year or anticipated to be reported sometime early next year to the middle of next year. And you can see some of the results at the bottom. CureVac was actually the one disappointment, but Zydus Cadila, then 2 protein vaccines from Chinese companies, one the Chinese company Clover, the other Zhifei, both of which showed the same kind of high efficacy, and with the Zhifei protein, and actually with Clover as well, efficacy against the Delta variant. So you see the vaccines that have already been approved, 28 of them. You see a list of additional vaccines. You know, do we really need more vaccines? Importantly, will this improve access to vaccines in low and middle income countries? And do these vaccines work against variants? Challenge number 2, from proof of production to from proof of vaccine efficacy to production in multiples of 8 billion. So this is a simple diagram of what UNICEF got from the companies when in the beginning of 2021 they asked, how much vaccine could you make? And you can see here that in the first half of 2021, the companies thought that they could make 7 billion doses, and by the end of the year, 12.8 billion doses. I mean, we're at 8 billion doses now in early December, so they were a little bit short of the total. But the IFPMA tells us that vaccine manufacturers are now making between 1.5 and 2 billion doses a month, every month. When you think about influenza vaccine, we make about 500 million doses a year in total around the world. We are already making an incredible amount of COVID-19 vaccine. The shortage in vaccines will not be a problem in the future. The bigger problem will remain equity and access. The reality of where the vaccines are and where they're going, you can see 21 billion doses have been secured globally. Well in excess of the 16 billion doses we might need to vaccinate all the people in the world. 8 billion doses have currently been given, and you can see the number of doses that have actually been purchased. You can also see, actually not so well in this graph, but better in some others, which vaccines were purchased by high-income countries in light orange, and then those that have been purchased by COVAX, the global entity to distribute vaccine all over the world, in gray. This is actually a better indication. You can see that there is a qualitative divide as well as the quantitative divide between high-income countries, like the United States and the countries in Europe, and then low-income countries in terms of what vaccines are available and what vaccines are currently being used. This is another indication of who has secured what vaccine, and again, in orange and yellow are the RNA vaccines. You can see the European Union, the United States of America, significantly represented with RNA vaccines. Other countries around the world have a little bit more difficulty in securing that vaccine technology. Part of the reason is logistical and cold chain related. And you can see that the United States, this is what Dr. Fauci mentioned, has promised 1 billion doses to COVAX by the middle of next year. Challenge number 3, COVAX and the promise of universal access. So just to remind everyone, we usually don't see vaccines getting out from the United States to developing countries in anything like a year. This is rotavirus vaccine. It was approved in the United States, FDA approved 2006. It was approved by WHO 2009. It was recommended by WHO for use in 2009. Now, 15 years later, 2021, 60%, 60% of the world's children have not received 3 doses of rotavirus vaccine. So it is not uncommon for innovative technology not to make it out to developing countries in a timely manner. COVAX intended to fix that. It was supposed to be a bridge to near concurrent access. 190 countries joined COVAX. It was organized by CEPI, the Coalition for Epidemic Preparedness Innovation, Gavi and WHO. 90 countries would get the vaccine free of charge. 2 billion doses of WHO emergency use listed vaccine would be secured by the end of 2020, would be delivered by the end of 2021. That's 20% of the estimated need. That would allow you to vaccinate all the people at highest risk, healthcare workers and the elderly. But it turned out to be a bit of a bridge too far. So the latest data from UNICEF are that 600 million doses have been shipped to 144 countries around the world, so short of the original total. And we know that this failure equity, and access has had three terrible consequences. The first is the humanitarian consequence. We already knew, and this was modeling done in May of 2020 by the Gates Foundation, that if we did not have equity in the distribution of the first 2 billion doses of COVID vaccine in 2021, global COVID deaths would double. Now, that was in June of 2020, there were 431,000 deaths from COVID. By November, we are at 5 million. So we are living out this prediction. The economic crisis was pointed out by the Brookings Institute, by the National Board of Economic Review, and by the CIA. That if there was not equity in the distribution of vaccine, 50% of the global costs of the COVID pandemic would be borne by high-income economies. That's $4 to $5 trillion this year. And then the biological one, which is one that virologists like myself worry about all the time, is that we know that variants come from uncontrolled outbreaks. So failure to control the pandemic generates mutants that could eventually undermine the efficacy of vaccines. And we saw that with Delta, and we're seeing it again with Omicron. This is what COVAX had hoped to do in orange. Those are the number of doses of vaccine delivered cumulatively through the year 2021. You can see in purple where they were in June. You can see the revised projections in turquoise from July to December. Now, remember that we were at 600 million doses delivered. That would put us well short of even our revised estimate for COVAX deliveries. Challenge number 4, the problem of universal delivery in an under-resourced world. So imagine 8 billion people, 16 billion doses, boosters, another 8 billion doses, variant vaccines, another 8 billion doses. So we're going to have to go from what we call the Extended Program of Immunization, EPI, which vaccinates 80 to 85% of children around the world by and large. Some countries, many countries, struggle to achieve those targets. We have to switch from 130 million children in the birth cohort to 8 billion people. IVI has already experienced settings where we are not able to carry out certain vaccination campaigns for COVID. Why? Because healthcare workers are engaged in EPI program immunizations and aren't available for vaccination. This was going to be a problem. There's a logistical problem, 8,000 jumbo jets to deliver 8 billion doses, so 16 billion, 16,000 747s. Quality assurance, that is tracking and recording. The ancillary supplies, gloves, masks, et cetera, weigh actually more than the vials. So again, something very important to think about. Access to vaccination sites, personnel, who are also a resource that is limited, and then transient populations. And so if you want to read more, the Absorptive Capacity Challenge by the Tony Blair Institute is instructive. Challenge 5, you can't fight an enemy you can't see and don't know. Dr. Fauci mentioned this. There is another gap. There's a vaccine equity gap, there's a diagnostics and sequencing equity gap, and you can see that in high-income countries, we do a lot of testing, in low-income countries in green, almost none. So how will you know where the outbreaks are? You can see that sequencing generates a similar problem. Luckily, South Africa has sequencing capacity. They're the ones who identified Omicron, but in much of sub-Saharan Africa, we are not tracking the sequences found in the pandemic. Then there's the Omicron variant, and Dr. Fauci has really gone through this, so I'll go through it very quickly. It's now 50% of the cases, of the sequence cases reported from Africa. Again, Omicron has 51 mutations, 26 in spike. You can see them down in the lower left-hand corner. All those little purple dots are the additional sequence mutations in Omicron. Dr. Fauci again has gone through this, but it's still too early to know the in vitro impact, that is the neutralization assays that we do. It's really too early to know the true clinical impact. And based on the observations, there are a lot of things that we can postulate. But remember now, and as we look at clinical outcomes, a lot of people have been vaccinated. And in parts of Africa, a lot of people have been infected. In some of the places that testing is going on now for phase 3 trials, up to 50% of the population have antibody already in the absence of vaccination. So the presence of previous infection will also mitigate disease. So let's wait for the data on Omicron. But again, outbreaks beget variants, and variants beget outbreaks, and we have this vicious cycle until we can interrupt the process of transmission. You can see examples of variants and outbreaks shown in the bottom slide. Challenge 6, science shouldn't stop when the when the vaccines are emergency use approved. You can see the things that we still need to work on: optimization of dose, schedules, the equality or equity of boosting, correlates of protection. Importantly, do we know a correlate of transmission or a correlate of durability of vaccination? What do we know about transmission and how to block it? Effectiveness, herd immunity, Dr. Fauci has already really talked about this. You can see down below, our phase 3 trials told us about efficacy, protection of individuals. Effectiveness trials tell us about direct protection of populations. What we really don't know and what we really want to know is impact. Protection, direct protection of populations, but also indirect protection of populations. I'm going to go through these fairly quickly in the interest of time, and Dr. Fauci has really gone through many of these. This is a very interesting study from Clover. They actually vaccinated people who had already been infected. So infection gives you efficacy of roughly 70%. The added benefit of vaccination, at least in the Clover study, was 79% additional vaccine efficacy in people who had been previously infected. And for all variants, it was 64%. So again, we need to vaccinate people who have been infected also. This is shown by Dr. Fauci. This is effectiveness data, actually a reduction in confirmed infections in Israel. I think many of us have probably already had boosters, and there are boosters in our future. Immune correlates of protection, very important. We think that it's antibody or neutralizing antibody or binding antibody. Effectiveness and herd immunity. There's, as Dr. Fauci said, a huge amount of effectiveness data out there. He showed some very interesting effectiveness data, which is real-world evidence. We have to remember that when we look at real-world evidence, we have to take it and understand what the potential biases are. Finally, challenge number 7, a comprehensive approach to COVID-19 prevention and control. And again, we have vaccines that reduce disease, reduce hospitalization, reduce death. We have monoclonals and antivirals that, if they're effectively used and distributed around the world, also prevent progression to severe consequences of COVID-19. We're less good at preventing transmission. We know that masks, hygiene, distance, and vaccination will reduce transmission. What we don't know is the impact of vaccination on transmission itself. And there are some data. There are preliminary data. It might be very important to get additional data. And of course, in Korea, we're still doing testing, tracing, isolating, and treating. Testing is very important because if we're going to use the antivirals and monoclonals effectively, we have to know who's infected. The final thing, and actually this is one, take me to your leader, Dr. Fauci's kind of busy right now, was for him. Do we lead leadership in a pandemic crisis? And I'm talking not about country leadership, but global leadership. Can we defeat a global pandemic without global responsibility and global accountability? Right now, we have multiple requests for funding, multiple sources of funding, uncoordinated disbursement of vaccines. The Ministry of Foreign Affairs in China reported that China sent 1.7 billion doses of vaccine out to the rest of the world, to 110 countries, more than is distributed by COVAX. 70 million of those 1.7 billion doses were actually donated to COVAX. Countries are using vaccines as a diplomatic tool rather than using a coordinated mechanism to distribute vaccine to the countries most in need. Finally, is there a plan? Who makes it? Who endorses it? Who funds it? And will somebody ultimately be responsible and accountable to world leaders for the execution of a complete plan for COVID-19 prevention? So IVI doesn't have its own vaccine. We made a decision early in the pandemic to help other companies with vaccine development. And you can see a list of some of the companies there. Some of the companies that we've committed to have promised 1.2 billion doses to COVAX. So we're hoping that the work that we do helps to get more vaccines into the global mechanism for COVID-19 control. Thank you.
So thank you, Dr. Kim. So we have time for some questions and answers. We'll just for a few questions. Unfortunately, Dr. Fauci can't be here, but fortunately we have Dr. Kim who can come back to the podium and answer maybe 1 or 2 questions. So please upload any questions to the YouTube chat as well if there are any. We'll get through to them. But to start with, I'd like to just talk about, you mentioned more than 8 billion doses of vaccines have been given. And there's been a lot of misinformation about some of these adverse effects. And can you try to, clarify some of them, especially since they are so rare, it seems, but it's been magnified in the news?
And so actually it's a really remarkable thing. We talk about rare adverse events. The blood clots that were reported occur probably in the frequency of 1 in 100,000 vaccinations to 1 in 200 or 250,000 vaccinations. That is an extremely uncommon event. That would be the equivalent to being killed by a lightning bolt if stepping out during a thunderstorm. And many of us have stepped out during multiple thunderstorms. So what we're talking about here are very, very rare events, and it's actually a tribute to the vaccine safety reporting system that we could pick up rare events like this all over the world, actually, in Europe first and then in the United States. When we talk about the myocarditis, again, a fairly rare event, 1 in 5,000 to 1 in 20,000, depending on the age of the individual. It's again, the systems for reporting vaccine safety exist and are robust in high-income countries. I want to point out, though, that in some of the countries we work in, there are 5 or 6 different vaccines in use. Records are not as well kept, and we really need to know the potential safety implications of the use of vaccines. So we need to strengthen safety reporting systems in all countries around the world. But again, when it comes to side effects, these vaccines have been incredibly well studied. The safety systems that the US FDA and the EMA and other countries have in place are robust, and they can catch very, very tiny signals.
Thank you so much. That really helps, I think. The other question I had was really about vaccine equity and, like you said, the patent sharing. Can you speak a little bit about that with companies? Has there been any inroads with trying to share the technology information?
Yeah, and so that's a great question. So, IVI in the development of its own vaccines doesn't take patents, hasn't taken a patent out. So, we really believe in what we call technology transfer, and we've done it to 7 different companies around the world, transferred vaccine technology. It's a little more difficult. It's not a short-term solution. It's probably not even a mid-term solution unless we talk about sending vaccine to a country and just putting it in the vial. When it comes to vaccine manufacturing, the know-how is really critical. At the same time, you have to have a regulatory authority that is capable of monitoring the safety and quality of the vaccines being manufactured. So we're talking about simultaneous strengthening of not only the technical and manufacturing capacity within a country, but also the regulatory capacity within those countries. So it's going to be important to be able to work with companies that have the know-how in order to do that. The final thing is, and again, IVI really does believe in technology transfer, and really, if it were in our power, we would transfer the ability to make these vaccines. But one of the really important things is, if you think about the heroes of this pandemic, was it the big vaccine companies? It was the biotechs. I mean, BioNTech partnered with Pfizer. Oxford University with AstraZeneca. Moderna never had a vaccine. It was a biotech. It is a biotech. The heroes in this, in the saga of the vaccine development are the small companies where innovation rests. What would it do if, during this pandemic, we were to say, you have to give up all your intellectual property without any compensation, without any cause? And what will it mean for the next pandemic? So again, I think we have to come up with a solution. It's going to take time, and through the WTO process, it will take time because consensus is required. So let's focus on getting as much vaccine out as possible. Let's work on the fill and finish parts so that we can get vaccine filled and finished all over the world. And let's also not forget, and IVI is working with WHO and with others to try and create a system for training people and strengthening regulatory authorities in order to be ready for vaccine manufacturing regionally in the future.
So thank you so much. That was on a hopeful note. I think that's all for the, maybe one last question is, what do you think about just the technology of mRNAs for other infections, or do you have a kind of crystal ball to look a little bit?
And so I think mRNAs are a remarkable technology. They seem to be great for viruses. I mean, hands down, as long as we know a virus, we know its sequence, we should be able to develop RNA vaccines relatively quickly. So they're ideal in this case for outbreaks. We don't know how well they work for bacterial infections, particularly those bacterial infections where mucosal immune responses might be very important. We have a whole series of pediatric vaccines that are what we call conjugate vaccines that have a piece of polysaccharide attached to a protein. it's difficult to, for right now anyway, to think of how the RNA vaccines will be able to mimic that unless they create such powerful and significant antibody responses or can direct certain types of T-cell responses, which again is something that RNA vaccines can do, to make up for the conjugate vaccines that we currently have that are highly effective, and they're actually on that table that I showed previously. They have high efficacy and high effectiveness, and they're in widespread use. There isn't a question. You know, it's funny, the average American parent, 80 to 85% of them get their children vaccinated. 26 different shots, 14 different diseases, most of them have never seen the disease. So these are vaccines, the current vaccines that we have, including the conjugate vaccines, are highly effective. Replacing them with RNA vaccines at this point may be a difficult thing to consider, but I think RNA vaccines hold tremendous promise.
Thank you so much, Dr.
Thanks.
Kim. So I'm going to be moderating. So I'm going to be moderating the second session on global health. So we're going to have 3 speakers and then a question and answer session at the end as well. So please upload them to the YouTube chat as well. I wanted to introduce Dr. Q Rhee. He's actually a colleague of mine and just recently promoted to full professor of medicine and microbiology and immunology at Weill Cornell Medicine. And his title of his talk will be Tackling Tuberculosis, Building Back Better.
Okay. Great. Well, thanks so much for the invitation to speak. It's a real honor and kind of a daunting task, but hopefully I can relay some interesting information that I think is particularly timely in light of the awareness that COVID has raised about the potential and widespread impact of infectious diseases. So a reason to talk about TB, of course, is that much like COVID, it is a leading cause of deaths due to infectious diseases, and prior to COVID was the leading cause of death due to an infectious disease, and has had a really disruptive effect on other aspects of not only human health but also socioeconomic equity. And so many of the same issues that are relevant and have drawn attention from COVID also pertain to TB. And so it's a timely and important thing to not forget about TB because at some point I am confident that we'll either manage to find a way to put COVID under control or ideally perhaps even reduce it to kind of a nuisance disease. But in the meanwhile, I thought I'd provide a kind of a slightly different perspective on TB and perhaps some recent clinical updates or advances in what we know. So to begin, what are the reasons to be interested in TB and why is TB important? And so the first, I think, is quite familiar to everybody in the audience, and that is that TB is a leading cause of deaths due to a bacterial infection. This slide is a little bit out of date, but it's, in fact, over time, it is the leading cause of deaths due to infectious disease over the course of human history. And numerically, this amounts to somewhere on the order of about 9 million new cases a year, about 1.5 million deaths, and on a more relatable time scale, that's about 24,000 new cases each day and about 12,000 deaths, of which 4,000 we record, and we know that we only capture about a third of the total number of deaths. So the next slide. The second reason to be interested or be concerned about TB, if we can advance to the next slide, is that TB has also emerged as a leading cause of deaths due to the growing problem of antimicrobial resistance. And in fact, it accounts for 1 in every 4 deaths due to a case of drug-resistant infection. And this numerically amounts to about 400, almost 500,000 cases a year, of which we're really only able to accurately identify probably about a fifth of them. And that the pill burden or the treatment course for drug-resistant TB involves an order of magnitude more pills than the so-called modern short-course chemotherapy that we're all familiar with. And that even in the even less likely scenario where one is able to obtain and actually take all of this, complete the treatment course for drug-resistant TB, the predictable cure rate is really only about 50%. So it's not only a problem because of its impact as an infectious disease. It's also a problem because of the growing issue of antimicrobial resistance. The third is moves a little bit more, I think, to kind of the socioethics of modern medicine, and perhaps relates to a topic that Dr. Kim just touched on, which has to do with health equity. Because in addition to being the leading cause of death due to a bacterial infection and the leading cause of death due to the problem of antimicrobial resistance, it's also the leading cause of death due to a curable disease. So this graph shows the leading causes of deaths from all diseases. And you'll see that tuberculosis sits on the bottom. But in fact, if one corrects the value for tuberculosis to include deaths among the HIV population, then the number of deaths due to tuberculosis actually equals or rivals that of diabetes as the sixth leading cause of deaths. And what distinguishes it from the list of other diseases on this slide is that it's the only one for which there's a predictable cure, at least for now, in the setting of drug-sensitive disease. So to some degree, this raises the question of how can it be that a curable disease is a leading cause of death when we have a cure for it? And in part, it's because of this slide. It's that because that TB is also a medically remediable cause and consequence of poverty. So because of its clinical impact, if you go to the next slide, you know that TB is debilitating, and that debilitation leads to unemployment and homelessness, and those are the conditions that promote poverty and then allow for the continued transmission of TB. And therefore, in resource poor regions of the world that don't have a public health infrastructure, then TB is a disease that is amplified by poverty and at the same time contributes to poverty, and yet is a curable disease. So the fact that it's the leading cause of death due to a curable disease, but is both the cause and consequence of poverty, means that it's a disease that is actually amplified by and amplifies poverty. And so on the one hand, curing TB won't cure poverty, but because of the global scope and impact of TB, there's no way to cure poverty without curing TB. And it helps, and it really, I think, is a societal indictment that, that in fact, it's the leading cause of death due to a curable disease, in part because of the fact that it tends to amplify and concentrate in those regions of the world that are least impoverished. As a consequence of this, tuberculosis emerged onto the WHO 2030 sustainable goals as a disease, as a target disease in relation to two of the key priorities. One, the first had to do with poverty, and the other had to do with health and well-being. And so if you move to the next slide, the challenges with controlling TB actually are in part what contributes to its continued dominance as a disruptive disease on human health and society. And there are three principal reasons for this. So the first is that unlike virtually every other infectious disease, TB is a disease in which having had natural infection actually confers no measurable increase in immunity. And the immunity to TB that exists is not sterilizing. And this is of practical importance because sterilizing immunity is basically the playbook or template for what a vaccine needs to do. So in the absence of clearly defined endpoints in terms of what type of immune response should be elicited by a vaccine, for TB, there isn't one. And in fact, there's data to suggest that having TB increases your likelihood or vulnerability for getting TB in a manner that's to some degree independent of the anatomical damage that's caused to the lung and the high levels of exposure in regions where TB is most endemic. The second is that, and so without a vaccine, it really makes the control of TB really a bit of a game of catch up, in that one has to go out aggressively and find cases. The problem, though, is that the diagnostics that we use to find and diagnose TB are really no different than they were almost 100 years ago, though we've made some recent advances that have helped to do this, but still remain inaccessible to the regions of the world that are most in need of it due to economic concerns. And that finally, that the treatments we have for it, while it is a curable disease, are really too slow, long, and toxic to be of practical utility in the regions that need it most. And in fact, to some degree, had we not discovered the drugs for treatment of drug-sensitive TB when we did, none of the currently used drugs would actually pass current FDA approvals. So the combination of these things have really kind of motivated in even more robust efforts to try to put this under control. And as a consequence of this, we were beginning to make some slow and steady progress in reducing the mortality of TB, both in the HIV positive and negative populations. And then, of course, next slide, about 2 years ago, the COVID pandemic hit, and the disruptive effect of yet another highly contagious and transmissible infectious diseases undid about 12 years of progress in TB control in only 12 months. And in fact, unfortunately, in 2020, this was the first documented year in over a decade in which there was an actual increase in TB deaths. And so if we don't continue to pay attention to TB, even if once we're able to finally get past COVID, it may well be the case that TB has reemerged and perhaps in a form that's even more difficult to treat than it is now. So it's important, I think, to stay alert to TB and to keep track and motivated to continue to make advances in the previous efforts to achieve control. And so what are the major advances that have occurred? Well, I think they fall into 4 major classes. The first is to really get better at developing better tools to find those at risk in terms of screening for latent infection. So if we move to the next slide, we'll find that, as we all know, there's been some progress there, and that in general, we've now replaced the use of tuberculin skin tests now with molecular tests, interferon gamma release assays that are, to some degree, a little bit more expensive or actually more convenient in terms of not requiring a second visit. And then next slide. After developing better tools for finding those at risk is to actually be able to treat those. And of course, historically, the mainstay of treatment has been the use of 9 months of isoniazid with B6. And of course, the advantage of this is that it was reasonably effective and inexpensive and really widely accessible. However, in the next slide, we'll see that the duration of the treatment for latent TB actually was a compromise between 6 and 12 months, where 12 months was better than 6, but compliance fell off, and that's where the 9 months came from. And as a consequence of that, there were a number of studies that investigated the use of alternative treatments. And so in the next slide, we'll see that, in fact, now we have 3 alternatives, each of which is shorter: 3 months of isoniazid with rifapentine, 4 months of rifampicin, or even 3 months of isoniazid and rifampin. So the days of 9 months of isoniazid and B6 may soon be a thing of the past. So in addition to those types of tools, we need better tools also to find more cases, not just latent infection, but actually active disease. And so this really highlights the importance of switching from historical microbiologic tests to the use of molecular tests, and in particular, the GeneXpert tool, first as a primary screening tool for cases of pulmonary TB, and secondarily as an adjunctive test for extrapulmonary TB. So the next, in addition to this, we also need to be more aggressive about developing better, faster diagnostics, because when we go looking and find more cases, we can actually measurably reduce mortality. And in this study, where they actually systematically went looking for active cases of TB, they were actually able to reduce overall mortality from TB by 50%. And so the final thing to do is to really look for better treatments. And so we're all familiar with the historical success of RIPE and the 442 and 244. And of course, it still remains effective, but as is shown in the next slide, it's really impractical because this is the pill burden that's required. And as I said, none of these pills would actually have passed modern FDA approval just based on toxicity. In addition, in the next slide, it turns out that to some degree, these regimens were developed as a matter of practicality because at the time, rifampin, which was an essential cornerstone of frontline therapy, was actually difficult to synthesize, and the dosing was determined among relatively young male in Hong Kong who had an average weight of about 45 or 50 kilograms. And it turns out that actually, in light of modern pharmacology, it's become clear that actually you can actually give higher doses or greater exposures of rifampin or rifampin equivalents and get more activity. And then in the next slide, this was actually put to test and shown that, in fact, when one increases the effective dose of rifampin, one can actually reduce the duration of treatment from 6 months to 4 months by making some adjustments in the dose or the formulation of rifampin type drugs that are given. In the next slide, not to forget the importance of drug-resistant TB, it's also become clear that we can develop better drugs and treatments for drug-resistant TB. And so I told you originally, it was 24 months, that was about 114,000 pills. That only gave you about 50% efficacy, but actually over the last couple of years, in the next slide, there have been a number of studies that have now come to the identification of regimens, 3-drug regimens that actually exhibit clinical success rates that rival those of the historical ripe for drug-sensitive TB. And so the last thing that I should say is that what about vaccines? I said that we lack, vaccines are essential, but a fundamental barrier is the lack of knowledge of correlates of sterilizing immunity. But it turns out that even with vaccines and enough effort, we can actually find, it's been possible to make progress. And in this study, there's actually been evidence of antigen-based vaccine with an adjuvant that appears to be able to reduce the rate of progression from latent to active TB by about 50%. So in the next slide, and my last slide, I'll just point out, so what comes next? So I think given the attention that's been given and recognition of the importance of not ignoring infectious diseases and its impact not just on human health, but also socioeconomic equity, it's important to reconsider and always think about infectious diseases through 4 lenses. And those are the 4 walls of defense, not the one that Trump wanted to build between the US and Mexico. And those are sanitation, nutrition, immunization, and antibiotics. And I think TB really is kind of, unfortunately, at the front end of this, and now is just shielded slightly by COVID, but is one that'll reemerge and which is likely to become more problematic if we don't continue to think about it while we develop new therapies and bring COVID under control. So I'll stop there.
Thank you, Dr. Rhee. So hopefully you'll stick around for a question and answer. So I'm pleased to present the next speaker, Dr. Lisa Park, Associate Professor of Ophthalmology, Columbia University Irving Medical Center. Her topic will be Curing World Blindness, a collaboration between Korea and Korean American eye surgeons.
I want to start again by saying thank you so much to the organizers for allowing me to participate in this fantastic convention. Today, I'll be talking about a medical issue that is often relegated to the sidelines simply because it seems relatively benign, and that is the ability to see. Visual impairment does not grab headlines like diseases which can kill people, like a viral pandemic, or like infectious diseases such as TB or HIV, or cancer or Alzheimer's disease, or diabetes or heart disease. However, I'd like to discuss a condition that affects not just a small segment of our population, but will eventually impact every single person who is currently logged onto this webinar, and every person in every country in every corner of the world if they live long enough, and that is the development of cataracts. Next slide. I have no financial disclosures. Next slide. And if you can play the video. This is cataract surgery. Just there's a arrow in the lower left corner. We make small self-sealing incisions in the cornea and carefully create an opening in a capsular membrane without disrupting the supporting tissues. We emulsify using ultrasound and aspirate the aging crystalline lens, and then we replace it with a permanent intraocular implant that allows one to see. In the hands of a good surgeon, this can take under 10 minutes. It requires minimal postoperative recovery, and in greater than 95% of patients, it results in uncomplicated visual improvement. Next slide. Cataracts develop as crystalline proteins in the lens denature, leading to the formation of insoluble, light-scattering protein aggregates. This can occur for many reasons. Cataract can be congenital, they can occur after trauma, they can occur with chronic steroid use, in the setting of ocular inflammatory conditions, and also after ophthalmic surgery, such as retinal surgery. However, by far the most common cause of cataracts is simply aging of the lens. In the US today, when we implant an artificial lens, we have the opportunity to correct not only the amount of light that enters the eye, but how accurately it is focused. In other words, cataract surgery has become refractive surgery, and patients often emerge less dependent on glasses. Next slide. And you can click through the technologies. This has been made possible to a number of technological advancements in the last 10 to 20 years, including highly accurate methods of measuring the eye, sophisticated calculations made by tracking large data sets of postoperative outcomes, and finely tuned surgical machines that minimize risk of damage to human tissues. Next. For those of us who are over the age of 45, we understand that the aging of the lens also results in reduced accommodation, meaning the need for reading glasses. Improvements in artificial lens technology, such as this multifocal implant, have addressed even that issue, so that a patient who undergoes surgery may gain both distance and near vision. You might ask then, if it is that simple and if it's so great, why doesn't everyone just have this surgery early? The reason is the following, and you could see if you go back, the implants are not exactly like the native lens, and there are some trade-offs, such as this, the most common being dysphotopsias, halos around pinpoint sources of light with this multifocal artificial lens. Next slide. But this is an area of hot research with new technology coming to market regularly, such as this extended depth of focus implant, and even next, light adjustable lenses, which have polymers that can be adjusted with UV light even after implantation to tweak the final refraction to a patient's satisfaction. The next area in which we have made significant strides is the correction of astigmatism. And this is where the optical system of the eye is not perfectly spherical. We often describe the eye as being shaped like a football instead of a baseball, so light is not focused as clearly. We can correct for this by implanting a lens in a particular orientation, or by reshaping the corneal surface with laser, and this is known as femtosecond laser. And that's next. And next slide. The other factor to consider when proceeding with cataract surgery, of course, is also surgical risk. Although the risks are low, they are not zero, and also not every patient is the same. And these are a few categories which I describe as higher risk, falling at the edges of the bell-shaped population curve. These include patients with extreme axial lengths, meaning people who are very nearsighted or very farsighted. These are individuals that have eyes that are shaped differently. The presence of uncontrolled diabetes can impact the healing that occurs after cataract surgery, apart from the retinopathy that can occur from the disease itself. There are also a few ophthalmic conditions that we examine for closely, including gutata, which is a low endothelial cell count in the cornea, which can result in postoperative corneal edema, and pseudoexfoliation of the lens capsule. This is a pathology of the epithelial basement membrane, which can result in capsular fragility and possible dislocation of the implant. The one that I also want to make sure I pointed out today is, in case we have urologists joining us during this talk, and that is the use of alpha-1 antagonists, particularly tamsulosin, also known as Flomax. And you can show the next slide. Use of this drug can cause floppy iris syndrome, which causes decreased dilation, billowing of the iris, and iris prolapse, which can result in increasing cataract surgery complications. For this reason, I tell every male patient of a certain age to come and see me before they start on any prostate medications. All of the advanced technology, and we can turn back, all of the advanced technology I have just discussed has made it possible to achieve reliable postoperative outcomes, but at significant cost and reliance on significant technology. The results are truly remarkable, and my patients come for surgery when their vision is simply an inconvenience. My office is near Lincoln Center in New York City, so they come complaining they can't do the New York Times crossword puzzle easily. Or pre-pandemic, they complained that they could not see the subtitles at the opera or could not drive at night. One topic that I don't have time to discuss is that I've heard from my ophthalmology colleagues in Korea that, and we are also experiencing in the US, much difficulty as the value of the services we provide are being challenged and the reimbursements for surgery are decreasing to unsustainable levels. It is a pressure that we must work together to educate our policymakers the value of what we do. It is also an ethical discussion about who will benefit from this field and technology advances. It is in this vein that we discuss the status of vision in the developing world. In places where there's poor access to healthcare, cataracts look like the following if we go back, and patients become blind. Next. With a global population of 8 billion people, 1 billion suffer from visual impairment. And in the next slide, 90% of this is treatable, either with glasses or with cataract surgery. Next. The highest rates of blindness are in South Asia and Sub-Saharan Africa. And the next slide. And in the present day, we talk a great deal about healthcare disparities, and globally we know that women receive less care in general, and it is also true in our field that women suffer from vision loss more than men. In the next slide, we see that although I said that visual impairment doesn't directly kill people, the data shows that blindness is actually associated with premature mortality at a rate 3-fold higher with true blindness. And the next slide, blindness also contributes to a cycle of poverty because those who cannot see cannot go to school, cannot work, and ultimately cannot contribute to the global economy. So that brings us to this. What is our responsibility to each other? I cannot pass up the opportunity to mention this Korean Netflix hit that took the world by storm, Squid Game. There have been many interpretations and reasons given why this series struck a chord around the world, and some of the themes include the economic precariousness we all live in, the ruthless competition to succeed, concept of collective sacrifice, and the ability of a country such as Korea to rise from poverty within a generation, while other countries have not. This desire to understand different cultures prompted this Korean doctor, Dr. Kim Dong-hae, to travel to a Muslim country after the events of 9/11 and begin the humanitarian NGO known as Vision Care. I know I don't have to describe the impact this organization has had to the Korean doctors in Korea because apparently Vision Care is known by every doctor in this country, and a third of Koreans ophthalmologists have actually participated in one of the over 300 humanitarian eye camps organized by Dr. Kim in the last 20 years. Next slide. I became involved from the American side in 2013 and have been traveling to East Africa regularly since then, mostly to Ethiopia, not only to perform humanitarian surgery for the underserved, but also to teach the local ophthalmologists modern surgical techniques. Next. I've recently had the opportunity to visit colleagues at Seoul National and Samsung Hospital, and as a full-time faculty member at Columbia, I've come to realize that ophthalmology training in the US is actually quite different from Korea. In the US, our trainees have their own patients and are required to show proficiency in cataract surgery and perform a minimum of 140 cataract surgeries to graduate. They do so under the most comfortable and easiest conditions. However, there is no organization in the US that has been able to do what the Korean organization Vision Care has been able to do, and that is to take modern cataract surgery technology, set it up in the harshest and most unforgiving conditions, and provide an environment to teach doctors in the developing world phacosurgery. In Ethiopia, there are approximately 100 ophthalmologists that serve a population of 100 million. Vision Care has now taught 20% of their surgeons through our annual PTC, a phaco training course. It is a 4-phase, 6-month-long phaco training course, and our early data analysis is starting to show a significant impact on clinical practice in this country. During this pandemic, we have converted to teaching virtually with US doctors providing Zoom lectures, Ethiopian physicians supervising the hands-on training, and Korean staff providing on-the-ground support. It has truly been an amazing collaboration and raising the level of eye care in this part of the world. Next is my last slide, and this is my daughter, who's a freshman at Harvard College. The center photo is her bike trip this summer. After high school graduation, she and my husband biked all over Jeju Island in 3 days. The photo on the right is Jessica volunteering on a Vision Care trip with me, where she saw global needs firsthand and was inspired. I hope my talk today has also inspired some of you. I hope it has provided some insight into the importance of eyesight as a medical condition. and I hope it ignites conversation about the distribution of medical resources. At the end of the day, my hope is that we all understand the power of working together to leave this world a better place for the next generation. Thank you.
Thank you, Dr. Park. So it's my pleasure to introduce Dr. Dong-Yeon Lee. He's the Chief Global Operations and Business Development at Seoul National University Hospital, and he will be speaking on Seoul National University's international missions in developing countries, the KEMA lecture. Thank you.
Thank you for the instruction. Hello, I am Dong-Yeon Lee, Chief of Global Operation and Business Development at Seoul National University Hospital. It is a great honor for me to be here today on behalf of Seoul National University Hospital. Today, I would like to present what our hospital has been doing internationally and how we support and encourage developing countries in need of improvement of healthcare service. Next slide. I would like to start with introducing Seoul National University Hospital. Seoul National University Hospital is the first national university hospital in Korea. For the past century, it has been protecting the health of the people in Korea as the nation's central hospital and has led to medical innovations as well as development. Next. SNUH provides optimal healthcare to the public with its vast network of 5 hospitals, including 1 medical checkup center. SNUH network has over 3,800 beds, providing medical care to 4.9 million outpatients annually, while having 14,000 employees, including over 3,000 doctors. Additionally, 2 more institutions are expected to open soon, so that we can expand the advanced medical infrastructure to the local community. The history of now prosperous SNUH network started from the Daejeon, the first westernized national hospital. It was followed by Daean Hospital, which had been used our main hospital building for decades. However, the history of modernized SNUH begins with the Minnesota project in 1945. Next. After the Korean War, Korea was left in devastated condition. At this time, the University of Minnesota signed a technical partnership agreement with Seoul National University. It was sponsored by the US government to help Korea become self-reliant by improving its medicine, engineering, and agricultural infrastructure, and even public administration. Next. One of the major goals was to help enhance the medical sector. Among them, the Overseas Fellowship Program was remarkably successful. 77 professors and graduates of SNU College of Medicine studied at the University of Minnesota and received training in the latest medical knowledge and skills. After returning to Korea, they further developed their skills and knowledge and transferred everything they learned to others by teaching and training, which tremendously contributed to Korea to live into a new chapter in medicine. Next. The project also helped our country build the foundation of current medical education and research. In particular, the medical education method changed from the theoretical Japanese style to clinically centered and experimentally oriented American style. In addition, an intern resident training system, as well as a 4-year nursing education program was introduced. Next. It affected the SNUH tremendously over time, even after the cessation of the 6-year program. If you look at the photos of the hospital in the 1950s before the project and the 1970s after the project, you can see how much significant progress SNUH has made in only a short period of time. Next. It is a history of SNUH. Minnesota project was the starting point for hospitals' reorganization and expansion. Next. Now I would like to move on to our international missions at this point. Currently, projects are being carried out in Laos, the United Arab Emirates, Uzbekistan, and China, with projects in Kuwait and Vietnam expecting us to start soon. Next. The first, I will talk about the project we are doing in Laos, which is quite insignificant for us in many ways. Next. The first project we did in Laos, Dr. Lee Jong-wook Seoul project, is very meaningful because it is literally the Korean version of a Minnesota project. In 2009, when Korea became one of the OECD Development Assistance Committee countries, Korea became the first nation with a transition from the recipient to the donor country in less than 60 years. As a result, in 2010, we embarked on this project and having been involved for 10 years. This project aims to improve medical technology and professionalism of Lao medical institutions and medical staff through various forms of support, and ultimately contribute to the foundation of the entire medical system in Laos. Next. SNUH provided various types of support both in Korea and in Laos, including regular training of clinical staff for a period of 6 months to 1 year, as well as invitational training for administrators in Korea. And equipment support of approximately $1.4 million was provided. The 10-year consulting project helped us many medical staff grow and improve the quality of medical care in Laos. But unfortunately, it was not enough to solve the fundamental problem of the Lao medical system. As an extension of the Lee Jong-wook project, SNUH had decided to be a part of a new project on the construction of Laos' first national university hospital to bring on the spirit and activities of the initial project. Next. In November of this year, SNUH signed a non-contract for EDCF project with the MOH of Laos to provide consulting services in construction of the first national university hospital of UHS, the National Medical College. The hospital will be a modern general hospital that meets the medical needs of Laos. Once the hospital is successfully built, we are hoping that it will greatly improve the current medical services, infrastructure, and as Laos's unique teaching university hospital in medicine, contribute to nurture the medical personnel. The simulation center, which will be built along with the hospital, will be helpful to educate medical students and personnel. Next. Now I would like to briefly explain about our project in the UAE. We've been operating the government hospital, Sheikh Khalifa Specialty Hospital, since 2014. It is located in Ras Al Khaimah, about an hour drive from Dubai. SNUH embarked on this journey with the hopes of making SKCH a top-notch hospital that can provide specialty care for the Northern Emirates community. As an operator and a manager of the hospital, SNUH dispatched more than 200 healthcare personnel for its medical service and knowledge transfer. It is a currently specialty hospital, mainly providing medical services in cardiology, neurology, and oncology. Due to our efforts to provide the best medical service, it has become one of the major regional hospitals in the area. Since the official opening of SKH of 2014, a countless number of Emiratis and expats has been able to enjoy the top quality care and excellent services of SKCH. We are now hoping to open more opportunities in expanding our business in the MENA region. The next country is Uzbekistan in Central Asia. Since 2019, next. Seoul National University Children's Hospital has played a major role in the Uzbekistan National Children's Hospital Education Project by the Korean International Cooperation Agency. The role of Seoul National University Children's Hospital is to build education and training center equipped with cutting-edge medical simulation equipment, establish a master plan of strengthening clinical competence in pediatrics, invite medical staff to Korea, and provide local training for various departments and specialists of pediatrics. Next is China, the country right next to Korea. In July 2011, SNUH decided to assign the contract for consulting on the establishment of operation of Yanji Hospital Checkup Center with the active participation and help of the Yanji City government. Due to the know-how and professional advice of SNUH, Yanji Center was successfully opened in 2013. And since the opening of the Yanji Center, SNUH has been conducting advisory business trips to the center every year to train local staff and provide quality services to patients. Next, the two countries are the countries where the project will be soon launched. I will start with Kuwait. Based on experience in operation of SKS in UAE, SNUH has been negotiating with the Kuwait Ministry of Health to manage and operate the New Jawar Hospital in Kuwait. New Jawar Hospital of NJH was built in 2018 with over 1,200 beds. Under this contract, SNUH will deliver clinical know-how in diagnosis and treatment and operation to Kuwaiti medical staff with our up-to-date researches and experiences. Also, Korean-made IT systems such as HIS, ELP, and smart hospital system will be installed and operated by the entire hospital staff. It will be a milestone of spreading our IT system in Kuwait public hospitals, as well as private clinics and hospitals in the future. Next is Vietnam, which has become Korea's core partner as Korea pursues the New Southern Policy, a policy of active cooperation and economic engagement with the Asian area. In line with the government's New Southern Policy, SNUH is trying to extend its consulting service to Vietnam to cooperate in the healthcare sector. The discussion began last year when Binh Mac International Hospital, one of the major international hospitals in Hanoi, requested our consultation for their medical checkup center. Thus, SNUH is expected to provide a consulting service on the operation and training of medical administrative staff of Vietnam and dispatch SNUH staff to Vietnam. Next. So as you can see through my slides, we have been working on a number of large and small projects in countries that need medical development and support over the past 10 years. And we came to know how difficult it is to produce tangible results and to elevate our country to the level that Korea has currently achieved. We realized that we had to invest more than 10 years of time and input all the efforts, even more than what he had put in so far. But we will continue to look for more projects, more opportunities in the future. As Korea has become one of the beneficiaries and know how important such programs like a Minnesota project are to the people in the country, with a strong sense of mission, we will not stop and continue to help and support those in need. Now, it's our turn to help. As a destination hospital in Korea, I look forward to the day when everyone around the world can have access to the appropriate medical services that they deserve. Thank you for your attention.
Thank you. So if you have any questions, please upload them to the chat. So I'll start with actually Dr. Lee, if you can come back, maybe the first question will be for you. So given the pandemic for almost the last 2 years, how has your outreach and kind of services to the other hospitals in other countries changed, and what have you done to try to, adjust to kind of the virtual training, if there is any?
Yeah, it's a good point and it's a very sad point that because we are already operating a hospital like SKSH in the UAE, they actually aided the UAE for the prevention of the spread of the COVID patient in that country. But as you can see in my slide, some kind of ongoing project and negotiation with the upcoming project was delayed for 2 years. So it is not good for them. But because we should play a central role in our country, so we can focus our internal role on that period. So I think it is a time to extend more communication and more opportunities in coming future.
Thank you. So my next question is for Dr. Rhee. Basically, you mentioned, the difficulty of having a vaccine for tuberculosis is the sterilizing immunity. It's difficult to have that, even after infection. Do you foresee any sort of advances regarding kind of vaccine development, just because it is very different than COVID, like you said?
Yeah, I briefly touched on it in the end, and I think the historical view was that we kind of had to know what sterilizing immunity was in order to develop a vaccine, and I think that really stalled efforts for quite some time. But because of the importance of that, I think the people have just decided to pursue more empirical approaches, and part of that has started to pay off. And the one that was reported in the New England Journal was actually completely unexpected to demonstrate any level of measurable efficacy, and yet it did. So I think it emphasizes that sometimes it's better to try than to overthink things, and when it's a matter of kind of, I think, timing versus urgency, then I think sometimes a little bit of luck helps, and I think, thankfully, with vaccine science, this seems to be the case.
Thank you. Next is for Dr. Park. With the Vision Care project, it's very exciting to see kind of surgery being done in resource-limited countries. What were some of the challenges of trying to set that up and training the providers there, or if there were any? I'm sure there was.
Some of the main obstacles are simply bringing the technology in country. And so it is actually, and when I said that I've seen no other organization besides Vision Care been able to actually take operating microscopes, operating machines, all the technology, all the implants, and actually set up in a place where the only thing that we need is electricity, which is not always reliable, and running water. And under those conditions, we're able to operate. I think that in surgical fields, we are very fortunate in that once a surgery is performed, that the postoperative care is very minimal. And that is the reason that really it's cataract surgery and cleft palate repair are the two that are really, we are able to bring to developing worlds and perform on a reasonable level. But this is a continuous challenge, and that is to modify the machines that we have so we can bring them in country. And so we have microscopes that literally we put together out of suitcases, and ultrasound phaco machines, which, we actually pack up and travel with. And that has been the greatest obstacle, but it is something that it can be done.
Thank you. For Dr. Lee, actually, regarding Korea's incredible, development over the last 40 years, especially in the medical education, what do you think was the success for how the training changed so quickly? Because, with bureaucracy, it can take a while for, organizations to adjust. So what do you think Korea's secret was?
I can define what is the actual reason for our success, but I realize that it is a very quite rare cases that have this kind of progress after in a very short time. But just I'm thinking that it depends. It is because of the dedication of the teachers who learned in the USA, like a Minnesota project. They did all their best to spread their knowledge and skills and bring up our level of expertise during their time in Korea. So I think that's the reason the teachers, the professors was the reason that we had a progress this much.
Thank you. Yeah, but it sounds like they were trained and then brought it back to this country. So for Dr. Rhee, for tuberculosis, just, a quarter of the cases are drug resistant, as you mentioned, and, there's been progress with the oral therapy that's much quicker. How do you foresee that? Has that been ramped up recently, just because it was released, the last year?
Yeah, I think, well, I mean, the challenge now is affordability and accessibility. And I think that's going to, I think the main issue is kind of figuring out how those are going to be paid for and distributed. But I think really it's a modern, really a modern miracle that that those therapies were able to be developed in a way that's significantly less toxic than I think the alternative that was previously much less effective. But this kind of highlights that, you know, it's not just the intrinsic efficacy of the treatment itself, but also the delivery that's every bit as important. And so we can't treat or cure infectious diseases without at the same time openly addressing issues about you know, socioeconomic inequity. Because if we don't, it doesn't matter what we do. If there's no way to deliver it, it's as though it doesn't exist. And to some degree, that's always been true of TB, and hopefully, you know, with kind of the awareness that's been brought by COVID, this will, and particularly the vaccine inequity related issue, that some of the solutions that emerge from that can be applied to some of the newer advances that come forth from TB research.
Thank you. And one last question for Dr. Park. So it's interesting regarding kind of the lens and like using lens surgery, kind of cataract surgery. How does that research come about? And it's, you know, since we are kind of, I'm a medical doctor, and so kind of the interesting part is to see all that technology with surgery being done.
No, it is an amazing thing. You know, I was very fortunate to be to train under the protege of the person who invented modern cataract surgery. And when we look back, it happened in New York in the late 1960s, early 1970s. So we're talking now, we've come upon 50 years where modern cataract surgery has been developed. And in that time, as you can see, the technology that has evolved is mostly in our imaging, measurements, biometry, our calculations. All of that technology has really come to the fore in the last, I would say, 10 to 20 years. But you can see then, even the adoption of the technology that we have from 50 years ago has not been adopted in the developing world. And so, you know, we're talking they're more than 50 years behind. Part of that is the technological aspects of, again, having just, you know, reliable electricity and certain infrastructure that would support that type of surgery. But the divide is becoming greater and greater now. And so I think that is our, you know, role as physicians is to be aware of it and to be on the cutting edge, and yet to understand now we're having increasing disparities in healthcare worldwide. So how do we overcome that?
Thank you for that final word. Actually, I think the theme for this session is inequality regarding kind of access as well. So thank you all for joining us. So thank you again for all the wonderful lectures this afternoon. And we're going to have a break until until 11:15. So it's 10:55 now. So we have about a 20-minute break. So thank you again. We'll see you back. One or two. Oh, thank you. I was like trying to be. So this is where the YouTube questions are supposed to be. This is the chat messages for that's going on, like with Ara and stuff on Zoom with the seekers. So nothing here. So it's just congratulations. Oh, hi, Dr. Oh, negative. Okay. Oh my God. I always worry. Thank you so much. 감사합니다.
This is the message.
Oh, okay. Thank you so much. Okay. Well, that's good. I was like worried. I know. I just get so panicky. So this is where, yeah, nothing happened here.
And then the slides are up. Welcome back now to this next session on the update in lung disease. After a really fabulous first sessions in global health, I'm very pleased to now introduce the next group of speakers. Our next speaker will be Bernard Park, who is the Deputy Chief of Clinical Affairs of the Thoracic Surface at Memorial Sloan Kettering Cancer Center. And he will be speaking to us about the innovations in surgery for lung cancer. Dr. Park?
Thank you so much, and I'd like to thank CAMA and the organizers for the opportunity to present today. I'm going to talk a little bit about innovations in surgery for lung cancer, and specifically I'm going to talk about minimally invasive sleeve resections for lung cancer. Next slide, please. These are my disclosures. Next slide. In general, minimally invasive surgery has become the surgical approach of choice for resection of early stage lung cancer. But more complex resections like sleeve resections, where you have to divide the airway and reanastomose it for locally advanced tumors, are still largely done by open surgery. However, there are a growing number of reports of minimally invasive series, both VATS and robotics, for pulmonary sleeve resections for lung cancer. The vast majority are from Asia, in particular China, where the incidence of lung squamous cell carcinoma is still relatively high. And the benefits of minimally invasive surgery mirror that of in sleeve resection of conventional lobectomy, such as shorter length of stay, less complications, and quicker recovery. Next slide. Robotic sleeve resection is even more uncommonly reported. There are a limited number of case series. The first two that were reported approximately 5 years ago were quite small, less than 10 patients each. Since then, there have been 3 larger series totaling about 116 patients. In addition, one series did compare outcomes with open VATS and robotic approaches. Next slide. You can see here the 3 main series of robotic sleeve resection. And the vast majority, as you can see, were right upper lobe lobectomies, which is the most common and the technically easiest sleeve resection to perform. And again, about 2/3 of the patients had squamous cell carcinoma. Next slide. I'm going to show you the benefits of and the innovation of robotic surgery for a more complex left upper lobe sleeve resection. Next slide. This is a case presentation actually of a 60-year-old Korean man. He was a former moderate smoker who developed the right upper lobe squamous cell carcinoma 5.5 years prior to presentation to our institution. He had a VATS right upper lobe lobectomy and lymph node dissection at Severance Hospital for what wound up being a pathologic T3N2M0 squamous cell carcinoma. He then received adjuvant chemotherapy and immunotherapy. 2.5 years later, he developed a right mainstem bronchial recurrence and underwent chemoradiotherapy to 63 Gray at Yonsei Cancer Center. Next slide. He was disease-free for about a year when he had a bronchoscopy showing a left upper lobe squamous cell carcinoma. You can see the pictures here. And because he had already received external beam radiation, he underwent endobronchial brachytherapy at our institution to 2100 centigrade in 3 fractions. He had a repeat bronchoscopy 3 months later without evidence of recurrence. Next slide. But about 5 months post-treatment, a bronchoscopy showed some mucosal changes in the lingula, and the biopsy was positive for recurrent squamous cell cancer. Even though he had a lobectomy, he had relatively good lung function, 77% predicted FEV1 and 66% of predicted diffusion capacity. So the plan was to explore him minimally invasively, try to do perhaps a lingulectomy with bronchoplasty or a sleeve lingulectomy to try and save as much lung as possible. Next slide. This would be the traditional approach, thoracotomy. Next slide. But we have had several generations of the robot. Here you see the first 3. Next slide. And the one we use now is the XI, which is about 4 years old. It's a 4th generation. The main thing you see here, advantage, is this rotating boom, which allows us to use very small instruments, 8mm cannulas, and the advent of a vascular stapler. Next slide. So this is the general incision strategy here, a camera in the 8th space, then 3 other incisions for the instruments. Next slide. We'll skip this. Next slide. The key steps for sleeve resection really are to do the hilar lymphadenectomy and to isolate all of the hilar structures before one divides the bronchus. Next slide. You can actually skip to the next slide. So I attempted to do, you can skip this. I attempted to do the lingulectomy, and you can start the video now. And you could see I cut the bronchus, but the margin was grossly positive. So I decided I needed to do the sleeve lobectomy here. So here, I'm just isolating the pulmonary vessels here. I already divided the lingular vein, and now I'm just dividing the rest of the upper lobe vein here. This is the robotic stapler I was talking about, so that I can have complete control of the instruments. Following division of the vein, then I want to look for the pulmonary arteries posteriorly. You can see them here, so I dissect them out. Are you able to skip forward on the video, maybe halfway a little bit? Oh, I guess it doesn't do that. It doesn't skip forward. Just go backwards, but if you go on the video, the previous video, if you should be able to skip forward in the video, if you can. If you can't, then that's fine. We can go to the next slide. You can advance. That's fine. You can let this run. So basically, what I had done is I divided all the rest of the structures, and I divided the main stem bronchus and the lower lobe bronchus. And now I'm just sewing the 2 ends back together. You can see I've encircled the main pulmonary artery here, and I'm holding it with a vessel loop. And one of the key advances in creating the reconstruction is that we have these special sutures that have little barbs on them. And this allows us to suture without having to tie any knots. And we don't have to worry about the suture slipping because they have barbed suture on them. So once you pull the sutures up, they will stick and they will hold. So here, I just put the needle through the loop here, and I just pull that up. And then I do the posterior airway first, and just pull that up. So I'll sew the posterior airway. It's a running suture. The robotic instruments are excellent because they really are wristed, and it's like you have your arms miniaturized in the chest. And you can just suture very easily. It doesn't require any additional training to what we already know as surgeons. So that's the main bronchus right there. And I'm sewing it to the lower lobe bronchus. And then you simply just pull up the suture and you pull it tight, and then you don't have to worry about the tension, and you just continue to suture it. Unfortunately, we can't skip ahead. I apologize. I underestimated the length of these videos. It's kind of nice to see the bronchial anastomosis completed, but in the interest of staying on time for the program. So, oh, okay, yeah. So you could start that video. So once I created the, can you start the video? Once I created the anastomosis, I wanted to reinforce it because if you recall, the patient had external radiation and he also had endobronchial brachytherapy. So minimally invasively, you can actually raise an intercostal muscle flap quite easily, and you pedicle the flap from the back, the posterior area here. And you can see with the robot, it's quite easy to do that. You can create a really nice, mobilize a nice piece of that intercostal muscle between the two ribs here. And what I'll do is I'll mobilize that muscle, and then I'll wrap it around underneath the pulmonary artery and wrap it on top of the anastomosis. Again, I just use cautery. I take my time here, and I can just mobilize this muscle quite easily. You can see here, the vision of the robot really allows me to mobilize this quite easily. I did this while the bronchial margin was pending. Usually takes about 30 minutes at our institution, so the timing worked out extremely well. But you can see, unfortunately, we can't skip forward, but I'll just basically mobilize this entire muscle flap, and I'll be able to bring that down and wrap it on top of the anastomosis. And once that's done, then I simply put one single chest tube, inflate the lung, make sure there's no leakage, and then the procedure is basically completed. But you can see, I just take my time. It's very easy to mobilize this this muscle here, and I just have to decide what length I need and where to divide it. But it's quite simple to do. Okay, you can skip to the next slide. So he did very well. So he had a left upper lobe sleeve resection. He was discharged on post-op day 3. His final pathology showed recurrent squamous cell carcinoma, had negative margins. Lymph nodes were all negative. We did not have to resect the subcarinal lymph nodes because those were taken at the time of his original operation for his right upper lobe. And he remained free of disease at a year with repeat bronchoscopy, CT, and PET CT. Interestingly, I did this case right before COVID started. So his case was done March of 2020. And he was discharged, and when we were checking on him, he reported that he was having low-grade fevers every day for about 2 weeks. No shortness of breath, no other symptoms. And actually, it turns out that he tested positive for COVID. And interestingly, even though he had the equivalent of essentially a pneumonectomy, because he had a right upper lobe lobectomy and a left upper lobectomy, I believe firmly, because he had a minimally invasive approach, he was able to not only recover from the operation very quickly, but he developed COVID, and this was before vaccinations were available, before there were any known treatments, and he remained an outpatient and basically survived having COVID just with fever. Next slide. So I hope I've shown in a short 15 minutes, and I apologize that I couldn't show the videos more extensively, but I think that robotic technology for surgery continues to innovate. It is now becoming the technical approach of choice for not only early stage cancers, but more advanced lung cancer surgery after chemotherapy or immunotherapy or targeted therapy. And it can certainly facilitate accomplishing complex lung resections. For sleeve resections, complete lymphadenectomy and complete hilar dissection is key. There's some new innovations in suturing, which simplifies the creation of bronchial as well as vascular anastomoses. And use of this technology really allows minimally invasive approaches to basically be on par with open approaches in terms of perioperative and long-term oncologic outcomes. I thank you for the opportunity to present, and I look forward to the discussion later.
Thank you so much, Dr. Park, for that really illuminating lecture on the innovation in surgery for lung cancer. It is now my pleasure to introduce the next speaker, Dr. Janet Lee, who is Professor of Medicine in Pulmonary Allergy and Critical Care Medicine at the University of Pittsburgh School of Medicine. And she will be speaking to us for the next few minutes on acute injury across the spectrum of lung diseases. Dr. Lee?
I'd like to thank the organizers for this opportunity to speak today. I'm delighted and honored to speak in this session on updates in lung disease. Next slide, please. These are my disclosures. Next slide. I've been in Pittsburgh for some time now, and Pittsburgh is on record as having the most bridges of any city in the world. And why are there so many bridges? Well, for one thing, the landscape is such that there are 3 rivers that converge at one point in Pittsburgh: the Allegheny, the Monongahela, and the Ohio River. Coming from Pittsburgh, I hope this talk and others at this wonderful scientific convention may provide another bridge or connection between Korea and the United States during this time of incredible change that is occurring globally. Next slide, please. The 2 objectives for this talk is, how do we define acute lung injury clinically? We define this clinically as the acute respiratory distress syndrome, or ARDS, and ARDS has never been more relevant than during the COVID-19 pandemic. But I also want to touch upon acute injury, perhaps in a different context, but no less relevant, that occurs in chronic lung diseases. 2 examples are acute exacerbations in bronchiectasis and chronic obstructive pulmonary disease. Next slide, please. Now, the function of the lung, as you know, is gas exchange. A local Pittsburgh physician, Dr. Sachs, had described the millions of air sacs, or alveoli, as grapes, where oxygen from fresh air can pass into blood, and also enables ventilation or carbon dioxide elimination. The millions of alveoli, as you can see in the cast of the lung, exponentially increases the surface area for gas exchange. Despite the enormous surface area, by necessity, the alveolar barrier, comprised of the type 1 alveolar epithelium, a shared basement membrane, and endothelium, shown by electron microscopy in the lower right panel, must be extremely thin, on the order of about 0.5 microns in thickness for unimpeded gas exchange to occur, and tight so that the fluid from the blood compartment cannot extravasate into the air spaces. Fundamentally, ARDS is characterized by disruption of this barrier membrane. Next slide, please. The initial description of ARDS was published in 1967 by Asbaugh and colleagues in a case series of 12 patients. And these patients had acute respiratory distress after infection or trauma, bore similarities to respiratory distress syndrome in newborns with hyaline membrane disease. This acute respiratory distress was characterized by severe hypoxemia, refractory to oxygen supplementation with impaired compliance, meaning that the lungs were quite stiff. It was responsive to positive end expiratory pressure, or PEEP, that enables stenting of alveoli so that one can improve oxygenation. And all the patients had diffuse opacities on chest x-ray. Next slide, please. The definition of ARDS has evolved over time, and ARDS clinically is defined by the Berlin criteria since 2012, which has essentially 4 components. 1, timing must be acute in onset, arbitrarily defined within 7 days. 2, chest imaging showing bilateral opacities consistent with pulmonary edema. 3, the edema cannot be fully explained by hydrostatic edema, such as in congestive heart failure or intravascular volume overload. And you need risk factors that can explain the origin of edema. 4, hypoxemia, with severity based upon the partial pressure of oxygen, or the PaO2 on an arterial blood gas, divided by the fraction of inspired oxygen delivered, or the FiO2, collectively termed the PF ratio, less than 300 in patients with a minimum PEEP requirement of 5 centimeters water. Next slide. Here is the actual Berlin definition. Next slide, please. Mentioned in the Berlin Consensus definition is common risk factors for ARDS that are provided in this table. But the vast majority of ARDS worldwide is due to infection, either direct injury from pneumonia or indirect injury from non-pulmonary sepsis, and collectively account for approximately 75% of cases. Next slide, please. Any clinical-based definition obviously has its pros and cons. Pros of the Berlin definition include the inclusion of explicit examples for radiographic abnormality, which I will get into in the next slide. It defined acute as 7 days or less and included risk factors and origin of edema without the need for the use of pulmonary artery catheter to measure capillary wedge pressure to exclude left atrial hypertension, as it did in the prior consensus definition. However, the cons include that it still requires invasive arterial blood gas to technically meet the hypoxemia criteria through the PF ratio. It still requires radiographic imaging, as we still lack a direct measure of lung injury, and minimal PEEP levels are required. The latter is an important point because this means anyone on high-flow nasal cannula is technically excluded from this definition, which is problematic since high-flow nasal cannula is becoming widespread for the management of acute respiratory failure. Next slide. Examples of chest x-rays consistent with ARDS were provided as supplement to the Berlin definition, and the 2 chest x-rays on the left column are consistent with ARDS. Next slide, please. The pros and cons of Berlin definition gets to the inherent challenges in how ARDS is defined. Part of the problem is that ARDS is a syndrome or a group of symptoms and signs that occur together and characterize a particular condition or abnormality rather than a disease per se. ARDS was originally linked to histopathologic findings of diffuse alveolar damage, which includes septal edema, intracapillary fibrin thrombi, intraalveolar edema, hemorrhage, and the presence of hyaline membranes. However, only about half of the patients meeting the current clinical definition of ARDS exhibits diffuse alveolar damage, ostensibly the sine qua non of acute lung injury on histologic examination. Next slide, please. Given the evolution of clinical care that has been catapulted by the pandemic, we need to evolve the definition of ARDS in the global era to include high-flow nasal cannula, incorporation of non-invasive peripheral saturation readings into the assessment of severity of hypoxemia, and importantly, we need a more diverse and international group of experts to reevaluate the consensus definition, because we may learn a lot more about origins of ARDS from different regions of the world, which is an important and first step in how we understand and devise treatment strategies. Next slide, please. As I mentioned before, when we look at ARDS worldwide, the majority is due to infection with pneumonia, comprising approximately 59% of cases and 15% from extrapulmonary sepsis. Next slide. And while we mention infection as a primary driver of ARDS, infection is also a common complication in ARDS patients, particularly those with prolonged mechanical ventilation. This study shows just how common infections are in ICUs worldwide, and the lung is the most common site of infection. Importantly, in the pre-COVID era, hospital-acquired infection showed higher mortality than community-acquired infection. Next slide. And just briefly, key components to the management of ARDS include treating the underlying process if known. For example, with severe COVID-19 infection, we now have dexamethasone and immunomodulators such as anti-IL-6 therapy and JAK-STAT inhibitors in our armamentarium. For management, lung protective ventilation with lower tidal volumes on the order of 6 cc's per kilogram, prone ventilation, and conservative fluid management. Unfortunately, there is no specific therapy for ARDS per se, but that might change as we evolve our thinking about origins of edema in the era of the pandemic. Next slide, please. To summarize, ARDS is common worldwide, still underdiagnosed and undertreated, and infection is a common cause of ARDS and a common complication in ARDS patients. Next slide, please. I now want to transition to focus on acute injury in the setting of chronic lung diseases, where infection is a prime example of an acute injury event that leads to overall clinical decline. And I'll focus on Pseudomonas aeruginosa infection in patients with structural lung disease. Next slide, please. We previously studied Pseudomonas aeruginosa as a trigger for experimental lung injury and focused on one of its virulence factors called Pseudomonas elastase, a type 2 secretion system exoproduct that directly induces tissue damage and barrier dysfunction. We recently asked whether Pseudomonas elastase activity was detectable in clinical ICU respiratory isolates and whether the presence of Pseudomonas elastase activity in these isolates in vitro was associated with worse clinical outcomes in ICU patients. Next slide. We've collected over 1,000 ICU respiratory isolates positive for Pseudomonas aeruginosa from over 800 discrete individuals thus far. And this recent work we published describes findings from the first 238 patients. Dr. Jill Zupatich, a pulmonary fellow at the time, showed that Pseudomonas elastase activity is common and associated with increased 30-day mortality. Next slide. We show that Pseudomonas aeruginosa isolates collected early in the ICU admission, defined as less or equal to 72 hours from index ICU admission, was driving the association between elastase activity and mortality. What this suggested to us was that these patients in the early sample subgroup are likely presenting to the ICU with Pseudomonas aeruginosa rather than developing it during the ICU stay. Next slide, please. Our statement is supported by the finding that the early sample collections are from patients with higher comorbidities, cystic fibrosis, prior stroke, COPD, and prior Pseudomonas aeruginosa in sputum. These are individuals with risk profiles compatible with Pseudomonas aeruginosa from the community and suggest that Pseudomonas aeruginosa elastase activity may contribute to acute exacerbation of disease. Next slide, please. To summarize, Pseudomonas elastase activity is common in ICU respiratory isolates and associated with increased 30-day mortality. Individuals with risk profiles compatible with Pseudomonas aeruginosa infection from the community may be driving the association, and Pseudomonas elastase activity may serve as a target for point-of-care biomarkers and novel adjuvant therapies. Next slide. Now I'll conclude with 3 points in this scientific conference focused on diversity, innovation, and cure. Related to diversity, we need to evolve the clinical definition of ARDS by increasing diversity and international perspective in the consensus definition. Towards innovation, we need to understand the origins of ARDS globally and reimagine therapeutic strategies to different origins of ARDS. Towards cure, we need to consider drivers of acute injury, even in the setting of chronic lung diseases, and consider targeting therapy to address drivers of tissue damage. Next slide. I thank you for your attention.
Thank you very much, Dr. Lee. I hope that Dr. Park and Dr. Lee can both stay on to answer a few questions. Again, we'd like to encourage all attendees to upload any questions to YouTube, and we'll be happy to ask our talented speakers about them. Dr. Park, the first question is for you, and that is in what has been an extraordinary year in terms of equity and diversity. I wonder if you could speak to what the access is like for some of the minimally invasive procedures that you had described, and whether this is something that is available mostly in specialty tertiary care centers.
Sure, that's a great question. I think that the robotic technology is very expensive. Systems now are somewhere in the range of $2 million US. In the United States, however, the majority of hospitals have at least one system, and the reason is because it has become the surgical sort of tool of choice for pelvic surgery. So, for instance, prostatectomy, hysterectomy. It's being increasingly used for general surgical procedures and thoracic. In the U.S., because of the fee structure of procedures, for the most part, patients are not charged separately for the use of the robot. That's different than other countries where patients have to have private insurance or they have to pay out of pocket if they want to use a robot. I am hoping, and because of the pandemic, I haven't traveled now for a couple of years, but even in the UK, it's being increasingly utilized across centers. So I'm hopeful that the amount of equity worldwide in terms of the patient access to this kind of system, this kind of technology is growing. But that's certainly a huge concern, no question about it. There are many countries and many patients that don't have access to this because of cost.
Thanks so much, Dr. Park. Dr. Lee, this question is for you. If you could help to elaborate on some of the risk predictors that perhaps might help to predict outcomes in patients with ARDS. You mentioned what appears to be a very heterogeneous disease with a wide array of clinical outcomes. In addition, you have an entity that's not well defined. So how do you then best try to identify these predictors that can help identify how patients will do?
You know, that's a pretty hot topic nowadays, particularly in the era of, I would say, machine learning. And many people have looked at this. I think there are ways to look at this in the ICU, particularly things like SOFA and organ system dysfunction calculations when patients come in. And those have been, for the most part, quite effective in addressing in this heterogeneous population. I think in terms of improvement or in terms of kind of specific ARDS, for example, COVID-19, I think that still is waiting to bear out. But that is a very hot topic, and I think more will be coming. I actually have a question for Dr. Park. I was kind of amazed by the robotic surgery, and I wanted to ask him, how long does it take for that procedure to from the beginning to the end, and compared to traditional surgery?
That's a great question. It kind of depends on the nature of the procedure. Sort of standard lobectomies are pretty comparable to open procedures or VATS non-robotic procedures. I would say the average lobectomy takes about 2 hours. That case took in excess of 3 hours because one of the reasons was because I kept checking the bronchial margins, and so I had to wait a little bit for that. And then the complexity of sewing the anastomoses, but really interestingly, you save a lot of time when you don't have to make a thoracotomy. So if you don't have to make a huge incision, divide all those muscles, and having to, sew them back together. So the times are pretty comparable. I would say overall, VATS non-robotic surgery is probably the fastest of the three options. But actually, once you're up on your learning curve, the robotic procedure is quite fast. And then if you are able to use it for more complex procedures, it actually cuts off a lot of time where you don't have to, again, create a large incision that you then have to close after the procedure. But once the beauty of the robotic approach is that it allows you to do complicated movements in the chest as if the chest was open, but you're just using small incisions. So.
Thanks very much, Dr. Park. Dr. Lee, the next question is for you. Dr. Park had alluded to his patient who developed COVID after a minimally invasive surgery and perhaps did better because of it. What is your experience with the impact of COVID in your patients, and specifically those without COVID and those with, and perhaps with both?
Yeah, that's a great question. I was kind of amazed by Dr. Park's patient before vaccination was available. That's kind of an amazing story. It's interesting, because there's been different phases of COVID-19 in the United States. And I don't know what it's like in Korea, but prior to the vaccination, we had waves and the New York region was particularly hit hard. A lot of the larger metropolitan areas. But recently, we've had maybe 60% vaccinated population. And what we're seeing now are probably the unvaccinated patients with very severe COVID-19 infection and ARDS. I would say the vast majority are those, and then the next are probably immunocompromised organ transplant patients. And then we do see on occasion the ones who are vaccinated, I would have to say they have probably less severe, even in the ICU. And so that's what we're seeing right now. So I can't stress enough, as Dr. Fauci had mentioned and Dr. Kim in the first session, how important it is to vaccinate, and also those who have had prior infection to vaccinate as well. I hope I answered your question.
Yes, you did. Thank you so much. All right, and then I think in the interest of time, the final question is for Dr. Park. And you alluded to the fact that perhaps surgeons who had not had exposure before to robotics can still easily adjust. Can you describe a little bit what that adjustment is like, and perhaps what the training period is like to become certified and competent in these procedures?
Sure. I mean, it's interesting, the robotic company is called Intuitive because actually, to be honest, using the system is quite easy. The learning elements are really, okay, well, how are you going to put the system in, right? How are you going to put those gigantic arms into the patient? So it's an incision strategy. But once you are able to make the incisions and get the arms in, then really it's just understanding how to handle tissue and really pay attention mainly to visual feedback, right? There's no tactile feedback with the robot. You're not holding tissue, your hands are not in the chest, and you're not holding the instrument that's dissecting the tissue. So it's really just about visual feedback. The learning curve for robotic surgery is probably, to become proficient, is at least 20 to 50 cases. And then if you want to really master it, it takes about 100 cases. So depending on your practice, your accessibility to the system, it probably would take somewhere around minimum 6 months to a year to get really proficient and at a mastery level for robotics. The training is pretty widely available now. There are multiple centers that the company has throughout the U.S. where people can train, as well as around the world. I believe, Yonsei University is one of the leaders in robotic surgery, in Asia, actually. So it's relatively easy to get trained, and then you really just have to have the cases and the team. But again, like I said before, most hospitals have very well robotic trained nurses, anesthesia, because again, this technology really is being used across multiple disciplines.
Thank you so much. I'd like to ask all of our attendees to join me in a round of applause for our two terrific speakers, Drs. Park and Dr. Lee. It's my pleasure now to conclude this program, and we'll take a break for lunch here in Seoul and perhaps at dinner in the US. And we'll see you back in a few hours for our next session, which will be on screening and prevention in cancer. Thank you very much. Good afternoon, everyone, and welcome back to the afternoon session of this symposia for the Korean American Medical Association. After what has really been a terrific discussion and Q&A with our many speakers and moderators this morning, we are now pleased to introduce and open this session of screening and prevention. We have two outstanding speakers today. The first speaker will be Dr. Sung-il Cho, who is the professor of public health science and chronic disease epidemiology at Seoul National University, and will be speaking on smoking trends and tobacco control policy in Korea. Dr. Cho?
Good afternoon. My name is Sung-il Cho. I'm a professor of epidemiology at Seoul National University. I'm very glad to participate in this wonderful symposium, and I thank you for the organizer for giving me this great opportunity. I'd like to talk about the smoking trends and tobacco control policies in Korea, and I'll start sharing my slides. Smoking is one of the leading risks for early death, premature death, and according to the recent Global Burden of Disease study, 8.7 million die from tobacco use every year globally. And among those, 7.7 million are the result of smoking, and 1.3 million are non-smokers who are dying because they are exposed to secondhand smoke. This data from a few years ago shows that the smoking is the smoking is at the second rank in contributing to the causing death, right after high blood pressure, which accounts for 10 million deaths, and followed by smoking, at this time 7 million, and then high blood sugar and air pollution, and so on, showing the impact of smoking globally. And Korea is, for male smoking, Korea is the third highest among OECD countries. Korean smoking patterns have some characteristics of large gap between male smoking and female smoking, and male smoking here, as seen as 30.5% of males smoking on average, is the third highest among the OECD ranks. Smoking attributable death in Korea in 2019 counts up to 58,000 deaths in 2019, a single year, and among the smoking attributable death, top three among men are lung cancer, pneumonia, and ischemic heart disease, whereas top three among women are lung cancer, pneumonia, and stroke. Global projection of the trends of smoking generally predicts constant decline, particularly thanks to global efforts under WHO leadership to reduce smoking. And from 2000 male smoking of 50% would be reduced to 35 by 2025. In Korea, we see similar declining trend, but faster among the male smokers, from 66 in 98 to 35 in 19, which is faster than the global trend, and also smoking among women are generally low, but recently slightly increasing among women. Smoking trends by age and gender in Korea shows that younger people, both in men and women, have higher smoking prevalence throughout the time trend, reflecting that smoking is initiated in young ages, so that the younger people have constantly high smoking rate. One specific feature in Korean women smoking is that in the old days, older women had a relatively high smoking prevalence, but very fast declined, and now it's crossing with a slightly increasing trend of smoking among younger women. Smoking in youth shows a similar trend of constant decline, with higher prevalence among boys and higher prevalence among older adolescents. This graph shows the attempt to quit among current smokers. So the majority of current smokers, more than 50%, had attempted to quit smoking during the past year, but they were not so successful. They are still smoking, and only 1/3 of them are still planning to quit, which reflects the difficulty of cessation. Smoking trend generally shows disparity between socioeconomic status by education, low education, and manual workers, and a low-income group has higher smoking prevalence throughout the time trend. Secondhand smoking is also another very important issue. Secondhand smoking has not been declined until very recently, in about 2013, and there was a strong expansion of tobacco-free policy around that time, and then that led to sharp decline of secondhand smoking at workplace and also public places. Both men and women experienced that declining secondhand smoke, but in contrast, secondhand smoking at home has been declining at a somewhat lower level constantly for quite a while, reflecting that the social norm has been improving about tobacco smoke exposure and its harms. ENDS, or electronic nicotine delivery system, also known as e-cigarettes, is a new challenge, and for tobacco industry, it's a new strategy to recruit new smokers. And after the tobacco tax increase in Korea, right before 2015, at the start of 2015, there was a sharp increase in ENDS use particularly among men, but later its use has increased among women too. ENDS use by gender and age shows that it's mainly adopted by the younger people in their 20s and 30s, and also for older people, they still adopt the ENDS somewhat later, but generally increasing in other ages too. WHO has been leading the tobacco control policy package globally to reduce the global burden of disease from smoking. It includes it's called Empower, including monitoring the tobacco use and prevention policies, protecting people from tobacco smoke, offering help with tobacco use, and warn about dangers of tobacco, and enforcing bans of tobacco advertising, promoting, and sponsorship, and raising taxes on tobacco to reduce demand. This global map shows the level of strength for each policy. These areas are where Korea are relatively strong, monitoring and offering help and warning by media are the areas where Korea has a stronger position. In contrast, for protecting from smoke and warning by product packaging label and enforcing bans of advertisements, tobacco advertisements, and raising taxes. These are the area where Korea is relatively weak. Particularly, Korea is weakest in regulating tobacco advertisement in convenience stores. This picture shows that typical convenience stores are covered with numerous tobacco advertisements. And this is even getting worse with increase in the number of tobacco ads per store recently. And these tobacco sales in convenience stores with these ads expose children and youth heavily every day. And government is not so willing to confront the store owner groups because they get substantial advertising revenues paid by tobacco industries. Korea also implements various measures to control the ENDS products. So in summary, I'd like to make some conclusion from the findings. So Korea has made a great progress in tobacco control during the past 2 decades, but there is still much more room for further strengthening at this point. And novel products such as ENDS should be also included in tobacco control. And Korea is stronger in targeting smokers with offering help and give warnings, but much weaker in regulating supply chain. And conflict of interest among those involved in tobacco supply chain, such as store owners, tobacco sales, people involved in tobacco sales, need to be resolved. These conflict of interest need to be resolved for effective progress because of their hesitancy to cooperate with this tobacco policy. This is the end of my presentation. Thank you very much for your attention.
Thank you very much, Dr. Cho, for sharing with us the experience in Korea. Certainly some similarities, but also some complexities here in Korea that are different from the U.S. I'm now pleased to introduce our next speaker, Dr. Joo-Ha Hwang, who is the Director of Interventional Endoscopy and Professor of Medicine at Stanford University. He is a friend and colleague, a fellow gastroenterologist, and he will be speaking to us today on gastric cancer disparities in Koreans and Korean Americans. Dr. Hwang?
Hello, I'm Joo-Ha Hwang from Stanford University. Thank you for giving me the opportunity to present at this important meeting. Wish it were in person. Was really looking forward to meeting everybody in Korea. Today, my talk is on gastric cancer disparities in Koreans and Korean Americans. It's a very important topic. It's one of the major disparities that exists for Koreans in the United States. I'd like to discuss the demographics and disparities of gastric cancer as it pertains to the United States. We'll discuss gastric cancer screening and surveillance and what it does, and then discuss briefly the management of early gastric cancer, and in particular submucosal dissection, if we can identify early gastric cancers as it prevents the need for surgery. So many people think that esophageal cancer is more prevalent than gastric cancer in the United States. And that's really because of all the funding and publicity and manuscripts that are on Barrett's esophagus and esophageal cancer. But it turns out that gastric cancer is actually more prevalent than esophageal cancer, which really surprises most physicians here in the United States because people think that gastric cancer is so rare. But it turns out esophageal cancer, there's about 19,000 cases of esophageal cancer in 2021, and there's anticipated to be about 26,000 gastric cancer cases. So it is not, it is more common than esophageal cancer. And I think one of the reasons that it's thought to be rare is the population that it affects. So the incidence of gastric cancer, as I mentioned, is rare. It's 10 per 100,000. So to put that in perspective, colon cancer is somewhere in the 35 to 45 per 100,000, which we screen for. If you break it down by race, whites are even less affected at 8.9 per 100,000. And then everyone else is more affected. So African Americans at 14.1. If you aggregate all Asians together, including Pacific Islanders, it's not that dramatically high, 14.3. But if you start to disaggregate groups, Asian groups, East Asians are actually quite high. And you have Japanese Americans at 24.2, and then the highest being Korean Americans at 52.5 per 100,000. That's important because that's actually a higher incidence than colon cancer in the United States, and we have no recommended screening guidelines for this population. A recent study published in Gastroenterology really emphasized the fact that Asians are disproportionately affected by gastric cancer. And so this is from the California Cancer Registry, and it shows that Koreans have a 13-fold higher risk for gastric cancer than whites in the state of California. And also equally affected or also more affected are Vietnamese, Southeast Asians, Japanese, and Chinese. But essentially, all Asian subgroups have a much higher risk of gastric cancer, but Koreans really stand out here at 13.3. So we need to do more in terms of identifying gastric cancers for Koreans in the United States, since we are disproportionately affected. Some more data to put things into context. Here, the green line shows the incidence of colon cancer in the United States, and this is basically what we are using as a barometer. We screen now, we're recommending screening at the age of 45. The blue line is US gastric cancer, and it's pretty rare. And then the red and purple lines are the Korean incidence of stomach cancer and colorectal cancer. And this is substantially higher than the US. And we know that the immigrant population has a similar incidence of cancer as the native Korean population. So again, there's a reason that in Korea there is biennial gastric cancer screening with EGD. And we really feel that this needs to be applied to Koreans in America as well. If you look at what Korea and Japan have been doing with screening, what it's resulted in is that there's a greater proportion of patients who are identified with gastric cancer at a localized stage. So 51% in Korea, 48% in Japan, and in the United States, only 28% are diagnosed at an early stage where the 5-year survival is better. In fact, in Korea and Japan, the 5-year survival, if diagnosed at a localized stage, is over 90%. And the overall 5-year survival is 67% in Korea, 64% in Japan, but in the United States, it's only 32%. And so we have a long ways to go here in the United States. And again, screening programs in Japan and Korea have really increased survival for gastric cancer. As I mentioned, the overall 5-year overall survival is much higher in Korea and Japan than it is in the United States or Western Europe. And the percentage of localized gastric cancers identified are much higher in Korea and Japan than in the United States or Europe. And this is data that Il-Ju Choi from the National Cancer Center provided us. And this is a comparison of the percentage of early gastric cancer diagnoses between South Korea and the United States. So Korea has implemented a national screening program for gastric cancer. And you can see that as the years go by, Korea is getting better and better at diagnosing early gastric cancer, to the point in 2016, 73% of all gastric cancers were actually diagnosed in an early stage. And this is why outcomes are so much better in Korea than they are in the United States. The United States, we've done nothing, and that shows. We're flat at 24% of all cancers, of all gastric cancers diagnosed at an early stage. And most of these are all opportunistic. You know, they had endoscopies for some other reason, typically not for screening purposes, and we just happen to identify them. So this is basically what we do if we do nothing. And the United States really needs to trend higher in terms of identifying earlier gastric cancer. The ASG actually has guidelines that are hidden in an obscure manuscript called Race and Ethnicity Considerations in GI Endoscopy. And they do suggest screening EGD for gastric cancer in new US immigrants from high-risk regions around the world, such as Korea. And so these guidelines do exist, but most people don't know about them. And so now to move on, why does screening work? So screening works because there's a premalignant lesion that we can identify ideally before it actually becomes gastric cancer. So the most common cause of gastric cancer worldwide is H. pylori infection. In the past, Korea had an H. pylori infection rate as high as 80%. It has come down now, so it's, I believe, less than 50% now, but still quite prevalent. But what we know is that H. pylori causes chronic inflammation of the gastric mucosa that then leads to atrophic gastritis and then gastric intestinal metaplasia. Gastric intestinal metaplasia is very similar to Barrett's esophagus, which is intestinal metaplasia of the esophagus. So as intestinal metaplasia develops and progresses, it can go on to dysplasia and then intestinal type gastric cancer. So the idea is to screen patients and ideally identify precursor lesions. And if we identify these precursor lesions, we can further risk stratify and keep an eye on patients who we really feel are at higher risk, which are patients with intestinal metaplasia. So a little bit more about intestinal metaplasia. This is a precancerous lesion for gastric cancer. Patients with intestinal metaplasia have a 6 to 8-fold increased risk of developing gastric cancer. Unfortunately, treatment of H. pylori does not cause regression of the intestinal metaplasia once it's become relatively widespread. Maybe for some small focal intestinal metaplasia that may regress, but for extensive intestinal metaplasia, it will not regress after H. pylori, but it certainly will slow down the progression and hopefully slow down the progression to cancer. Additional risk factors associated with intestinal metaplasia include an incomplete type, which is a pathologic subtype of intestinal metaplasia. Again, extensive involvement involving the antrum and body, or intestinal metaplasia involving over 20% of the gastric mucosa. This is an endoscopy demonstrating intestinal metaplasia. So on white light endoscopy, it can be difficult to see, but if we switch to narrowband imaging, then intestinal metaplasia and atrophic gastritis is actually quite easy to see. This is a lesser curve of the stomach. This is the GE junction. This is my scope retroflexed on it. And you can see that the intestinal metaplasia goes up the lesser curvature of the body. This is the incisura or angularis of the stomach. This is the antrum. So this shows kind of the traditional pattern of involvement from H. pylori gastritis with atrophic gastritis involving the antrum, incisura, and lesser curvature of the stomach. So we know that gastric intestinal metaplasia is an increased risk factor for gastric cancer. This is a retrospective study that we did when I was at the University of Washington. We also showed that being of East Asian descent is gives a high odds ratio of 16 compared to other Asians. So we were able to disaggregate all Asians and separate out East Asians, which included Koreans, Japanese, and Chinese, as well as Vietnamese. Others had some slightly increased risk, but not as much. And interestingly enough, H. pylori infection alone did confer an increased risk, but nothing compared to once gastrointestinal metaplasia developed, and again, of East Asian descent. So if intestinal metaplasia is present, then the ASG also has guidelines that says that this should be surveyed, especially people with an ethnic background or family history of gastric cancer, or that puts them at higher risk of gastric cancer. The AGA recently came out with some controversial guidelines. Actually, when they first came out for public comment before they were published, the recommendation was that they suggested against routine use of endoscopic surveillance, which I thought was actually not right. And so we campaigned the AGA and got a petition together asking for further clarification in the recommendation, because we felt that patients who are in high risk groups really should have surveillance. And so they did go on to state that, again, this is a conditional recommendation, very low quality of evidence, and that they stated that patients with incomplete type intestinal metaplasia, extensive intestinal metaplasia, family history of gastric cancer, and then more importantly, patients who are at increased risk due to race and ethnicity, such as Koreans, and immigrants from high incidence regions, such as those from Korea, should be considered for screening. So we thought that was important. Also important is that there's cost effectiveness studies that show that screening for gastric cancer is cost effective in Asians, Hispanics, and non-Hispanic Blacks. The only group that it is not cost effective in is non-Hispanic whites. So this is a cost effective strategy to screen. We recommend screening on index colonoscopy for high risk groups. And the reason for screening is that you want to find early gastric cancer. So this is in the antrum of the stomach. This is an early gastric cancer in an Asian patient. We did chromoendoscopy with indigo carmine, further outlining the lesion. It's slightly depressed, but then what we can do is we can inject fluid and expand the submucosa. So we're taking a needle, we're injecting fluid into the submucosa, separating out the mucosal layer and the muscle layer. And then we're able to actually dissect out and locally resect early gastric cancers, as opposed to having patients go for major gastric resections surgically. So this is an organ preserving procedure. This was actually done as an outpatient. Patient went home after this procedure. I know in Korea they're typically admitted, but we were able to suture this site up after the resection, and the patient was able to go home after the procedure. And so this saved the patient from having a gastrectomy and improves the quality of life. And studies have shown that endoscopic resection of T1A lesions results in similar survival and similar outcomes with improved quality of life. So this is me suturing the lesion closed, and this is after we've closed the entire defect, and this is the specimen that we resected. So who's at risk in the United States? Obviously, this is the third leading cause of cancer deaths worldwide. So from anywhere in this heat map that is red, these patients should undergo screening, and especially for Korea. For some reason, we like to excel at things, and we excel at having gastric cancer, unfortunately. But this is all the more reason that any patients beginning at the age of 40 should be considered for endoscopy to screen. And if they have H. pylori, they should definitely be treated. So my take-home points, the high-risk populations in the US are East Asians, especially Korean Americans, Hispanics, and patients with a family history. There's a pre-malignant condition that we can screen for, which is intestinal metaplasia, which is very similar to Barrett's esophagus. There are no current guidelines for gastric cancer screening in the US, which we need. High-grade dysplasia and early gastric cancer can easily be managed endoscopically without the need for surgery. And we need to improve outcomes in gastric cancer, and prevention and early detection are key. So with that, I thank you very much for this opportunity. I would like to let you know about a gastric cancer summit that we will be holding at Stanford in 2022. This will be in person on March 10th and 11th, and I welcome you to come to sunny California at that time. So thank you very much.
Thank you so much, Dr. Huang. We're happy to take questions. I'd like to encourage all attendees again to input any questions into the chat on YouTube. In the meantime, we have a few questions here for Dr. Huang. Dr. Huang, I wonder if you could share with us some of your experiences where Koreans and Korean Americans have perhaps banded together to address this important question, and specifically how we best can learn from the Korean experience.
Sorry, I was muted. Yeah, I mean, I think that these efforts have been going on for many, many years, even before I got involved. In the U.S., as you know, there are many pockets of Korean American physician communities, and the real issue was trying to get this going on a national level. And recently, there was this Asian American Stomach Cancer Task Force that was formed out of New York that they asked me to chair, and I think that's really the start of the national effort on behalf of all Asians, and it's really increasing awareness. You know, the data's out there. That's what's so tragic about this, is that the data's out there. This is probably the biggest disparity that exists for East Asians and especially Korean Americans, and so I just felt really compelled, especially as a gastroenterologist, and I know that you're getting involved as well, that, you know, this is something that we have to do for our community. So I think that we're gaining speed. That's what I created this gastric cancer summit for. It's Stanford. It's really to bring the entire community together, and it is really, the goal is to get screening guidelines in the United States by the United States Preventative Health Task Force, the USPSTF, so that we don't have our patients having to pay high deductibles for a screening examination.
Thanks so very much. You had mentioned some difficulties in getting disaggregated data. As you and many of our audience members know, the Asian American experience is a very heterogeneous one. And so I guess what will it take to get the necessary level of detail, do you think, for Korean Americans to understand what exactly is happening?
Yeah, we need disaggregated data. I think that we need to convince health systems, and I think EHRs are helpful if we can get groups to start identifying specific ethnicities. And I think that California, of all places, has had a head start on that. So that's why we do have some disaggregated data that I presented in the talk on where we're at, that really, magnifies. I didn't think it was that bad, but I think the data out of California really really magnifies the disparity that exists. And again, we've established, here we have the Center for Asian Health Research and Education, and one of our main missions is really to push nationally to disaggregate data. We live in the Bay Area, and it's almost 50% Asians here, right? But we're not all the same Asians, and we need to disaggregate the data.
That's fabulous. It's a terrific work that you're doing. As you know, you and I are sort of the same mind in terms of gastric cancer screening, but just to play devil's advocate for a moment, do you see any risk of harm, potentially in overscreening a population perhaps that doesn't need to be screened, or do you think this is something that we can address if we institute a gastric cancer screening program?
Yeah, I mean, this is an invasive screening test, but if you compare it to colorectal cancer screening, where most of the screening that we do in the gold standard is a colonoscopy, this is a much less invasive test. And if you use logic, right, especially for the Korean population, the risk of gastric cancer is actually higher than that of colon cancer, and the cost is lower, especially if you combine it. Then there really is no added risk, and so. From a logical perspective, I would say that although it's an invasive procedure, it's a relatively safe invasive procedure. The main risk is associated actually with the anesthesia that's administered, and so if we combine that with colon cancer screening, then I think that the risk is significantly mitigated.
Thanks so very much. I think with that, we'll probably close this session and actually get started on our next one. But thank you so very much, Dr. Huang.
Thank you. Everyone stay safe.
It's now my pleasure to introduce the next moderator, who is Dr. Ara Lee, who will be opening the session for international health.
Hello, I'm Jennifer Lee. I'm the scientific chair for the CAMA Convention Committee for 2021, and I am honored to introduce the moderator of our next session, Dean Augustine Choi, who is the Stephen and Suzanne Wise Dean at Weill Cornell Medicine, my home institution, and Provost for Medical Affairs of Cornell University. And I do feel I have to say a few words about him before he takes the stage. Prior to his appointment as Dean, he served as the Sanford I. Weill Chairman and Professor of Medicine in the Joan and Sanford I. Weill Department of Medicine at Weill Cornell Medicine, and as Physician-in-Chief at New York Presbyterian Weill Cornell Medical Center. And throughout his prolific and now historic career, Dean Choi has authored more than 365 peer-reviewed manuscripts and is currently active as the principal investigator of multiple NIH R01s and the NIH NHLBI program project grant, and is an elected member of the National Academy of Medicine. And Dean Choi will introduce the speaker of our next session on international health.
Thank you, Dr. Lee, and good afternoon, everyone. It's really a pleasure to introduce you our next speaker, Dean Javed Sheikh. Dean Sheikh is Professor of Psychiatry and Population Health Science at Weill Cornell Medicine at Qatar. And since he's been at Weill Cornell Medicine Qatar for the last, as Dean since 2010, Dean Sheikh has really led globally in becoming a internationally renowned medical executive and really a leader in global academic medicine and population health. He has implemented and pioneered innovative research and educational modules as an international platform, and you'll hear most of that today in his talk, and I won't go into that some more. And prior to coming to Weill Cornell Medicine Qatar, Dean Sheikh built a distinguished career in psychiatry and behavioral sciences at Stanford University School of Medicine. He served as an associate dean. He served as the chair of the board of the Palo Alto Institute of Research and Education in the Bay Area. So again, it's a pleasure to have Dean Sheikh come to Seoul, Korea from Doha, Qatar, and it's really a pleasure to introduce my colleague and friend, Javed Sheikh. Dean Sheikh.
Thank you, Dean Choi. Thank you for very kind comments. Good afternoon to all of you. It's a pleasure and an honor to join you here at this scientifically rigorous and very high standard conference very special thanks and congratulations to President Mary Choi, President of CAMA, and the Executive Committee of CAMA. So it truly is an honor and a pleasure. As Dean Choi said, that I'll be talking about innovations in global health professions education, but as part of that, before I get to very specific information, I definitely want to look at the larger picture, the larger context, because the innovations in global health professions can only work when one looks at the larger picture, diagnoses the problem, and then, of course, we can get to the interventions. So this thing, let me see, I hope I'm going to do this right, because, right, just a second. No, I went, yeah, we're good. So what is the larger context? The larger context is that before the pandemic started, the healthcare systems globally were already under stress for the last 5 decades, as all of us are quite familiar, non-communicable diseases, metabolic syndrome, diabetes, cardiovascular disorders, and increasingly cancer also attributable to metabolic disorders, and they have been stressing the system in the last 2 decades. Globalization, rapid urbanization, mass migration, and this is again before the pandemic, emerging and new infections, well, re-emerging infections like tuberculosis, and now we have the epidemic here. The healthcare models, particularly in the US, but I would say elsewhere in the Western world, you would know more about Korea, but I would imagine it would not be very different, although your healthcare system seems to be quite functional compared to where they are mixed models. The healthcare models have focused on acute illnesses and hospital-based care, as opposed to a continuum of care. And increasingly in the US, we have become very aware that there are health disparities and major shortages of health professionals globally. Dr. Anthony Fauci noted in his presentation this morning that in developed countries, the rates of vaccination are somewhere between, let's say, 85–90% in many of the countries. But in the developing countries or the poor countries, they are like around 6%. So it's really a major disparity between the countries and within the countries. What happened during the pandemic? Well, all of these stress systems, many places, they really broke down. Health disparities became much worse. But there was some good news. Some of the trends of digitalization which were in place, they became accelerated, and I'll share with you some of the examples. And because of that, digital medicine became increasingly a focus, and it became a tool to address some of the accessibility, affordability, and quality issues. In addition, technology-based solutions, including wearables and apps for wellness, as well as AI-based diagnostics and improving precision in treatment selection, have become better accepted. And the trend was going on for a few years, but it has definitely accelerated. So that's a larger picture. Now, for people who dream like myself, one has to really look at how do you transform a system or global healthcare systems which are really not functioning very well, because we are operating under models which are from the 19th century, and similarly our educational models. So how do you transform them? Well, at least we can exercise our theoretical formulations. So the requirements would be for really the governments to come in, change the policies to achieve financial sustainability, and focus on easy accessibility and value-based healthcare, which means improve quality and positive outcomes, and that's what the healthcare needs to be based on the outcomes. A greater focus on wellness and population health, and now this is something which has been talked about for a while, but has now become the mantra and better accepted globally during the pandemic, which is good. Research innovation is pretty much non-controversial area that we need to continue developing diagnostic and therapeutics, and where I will focus on is 2 areas where leveraging technology to enhance access, affordability, and quality of care, but mostly on innovations in health professions education. So this is a very complicated slide. I'll try to simplify it for you. This is from the think tank called IQ. This is a nonprofit, like a RAND Corporation of human data science, combining healthcare data with large data and looking at multiple areas where during the pandemic, the trends have accelerated. They actually talk about 12 or 13 different applications. I would simplify for you. There are 4 areas in general where if one remembers those 4 areas, I think we pretty much can come up with solutions. One is enhancing wellness, to get consumers involved with consumer apps as well as wearables. Number 2, to get into more refined diagnostics, the imaging, the dermatologists, pathologists, radiologists, all of them, how to use technology, AI-based and advanced data analytics to improve diagnosis. 3 is really precision medicine, starting with cancer biology and now increasingly in other areas. And 4 is looking at the healthcare systems in themselves. How do we make them more efficient? From the time the patient registers to the time that they leave, how do you run them more efficiently? Actually, one of my colleagues at Stanford has created this WISE OR, whereby, they are trying to fix it, and what he tells me is that the inefficiencies, percentage-wise, are like 40, 50, 60% of the resources are consumed by the inefficiency. So that's where the technology, data analytics can be very helpful to the healthcare systems. Now, let's get to the innovations, health professions, education. So that was a larger context, and that's where we come in. So the first slide is rather obvious. What are the current gaps? The current gaps are, some of them I touched on earlier. There is time-based training instead of competency-based. Basically, the residency is 3 years, 4 years, 5 years, depending upon the specialty, but it is really not looking at where the trainee is at in terms of their competency, acquisition of skills. The emphasis on acute care, as I said earlier, instead of a continuum of care. There's a lack of focus on population health and wellness. I touched on that earlier. Inadequate training in statistical reasoning, data science, and the use of information systems. And because of all of this, complete mismatch of the competencies which are really needed out there now compared to what we do and how we are trained. This is, again, a complicated slide, but I'll simplify it from Eric Topol's very well-known book a couple of years ago on deep medicine, looking at data science and looking at what is coming down the pike. But it really is, to me, it was an alert to the educators that this is what we need to look at to start preparing. There is going to be a deluge of data coming our way. Individuals, multiple levels, all kinds of omics. And then beyond that, we are going to get to environmental data, the family history, this and that, and yes, of course, updated information on all kind of healthcare resources. So let's get ready. And then on top of that, what we know is already happening is the new training platforms are coming online. They are in place and they're coming online. So we have Anatomage, we have virtual realities, but now the mixed reality is coming in there where you have avatars and holograms, and they are coming on your way. And once you get used to those, and I've seen some demonstrations and we have some on order, you would not go back because they truly give you the kind of immersive experience which is very different from the old Anatomage experiences. Then, of course, the whole issue of algorithms and data analytics, which are in place and which are being increasingly used both for diagnostic and recommendations for treatments. Data repositories are available for the trainees which are in public domain where the unstructured data has been cleaned up and the trainees, the senior trainees, can learn without very extensive training in data science how to do data analytics and how to conceptualize issues and problems using the data. So those are some of the improvements which are taking place. Now, it's a busy slide. This is a wish list on my part, a part of an educator, in terms of what kind of competencies would be needed going forward. So again, to simplify it for you, what I'm recommending here is that there are 6 areas where we would need to have new competencies. The top three, which is increased emphasis on population health, the principles of value-based care, and understanding policy, social determinants of health and business of medicine are the larger issues competencies. The bottom three, which is a continuum of training and increased emphasis on social and behavioral sciences and professionalism and leadership, and finally, of course, foundational training in data science and digital medicine and AI, in addition to recognition and familiarity with healthcare-related applications of AI, those are more specific. So the top three, very broad, unless one addresses those in terms of competencies, the trainees coming out truly would not be ready for what is in store for them, the deluge of data and population health needs and the principles of value-based care and the alignment of undergraduate medical education with graduate medical education, with continuing professional development. Unless we do that, we really would not be preparing our trainees as well as we ought to. Not to talk of professionalism and leadership. Leadership in particular for matrix systems. I mean, we physicians are very used to hierarchical systems, but increasingly there's going to be team-based training also, particularly using AI tools. So the leaders need to learn how to be leaders in matrix organizations by using the art of gentle persuasion as opposed to the diktat. Finally, as we prepare with the new competencies for future, we also need not to forget what really works in terms of relationships with the patients, but we need to have a renewed emphasis on humanism in training. The old empathy, the caring and compassion, the connection, the communication, the social cultural training, all those things are absolutely essential. It's a well-known saying that is really the relationship which heals. It's the meaningful connection with the provider or the doctor or whatever healer word that you want to use. So we absolutely have to emphasize those also in addition to the new competencies. And the net result really is, yes, it's a trite saying, it's a techy thing, but it is going to be high-tech and high-touch. We have to prepare our students for high-tech, no question about it. But at the same time, we cannot underestimate or undervalue the humanism in medicine. So it needs to be high-touch also, better relationships. So how are we going to do that? So it's not only a theoretical, wishes and dreams of a philosopher type. I mean, that's what I wanted to be when I was a young kid. But anyway, we practically speaking have created an organization called Innovations in Global Health Professions Education in partnership with the National Academy of Medicine in the US. It's called IGHPE. It's a forum, global forum, a platform. It's an open access journal. It is a platform for rapid dissemination of ideas and to organize conferences from all over. So we have done in Europe, we have done in Asia, we have done in Malaysia. We have affiliations with multiple organizations in Asia here now, of course, with CAMA also. And our goal is really to have three major strategic priorities, which is to advance the science of learning of health professions everywhere, using American system, but make it affordable to everyone, to promote sustainable solutions. And finally, to me, probably most important really is to spread and nurture communities of cross-cultural learners, which means the scalable models, innovation, which are locally relevant. Okay? Same standard, global standards, but locally relevant. So what have we done? Well, this is proof is in the pudding. This is our home-cooked meal. For the last 12 years, if you look at this slide, in the middle is our original mission. We are the first medical school outside the US which gives out US degrees. As Dr. Choi said, we are a campus of Weill Cornell Medicine in New York. So initially, our goal was to create a 6-year system. It was initially 2 years and 4 years separate, but now we have integrated a 6-year program to give degrees. But what we learned was that the local students were just not ready for that high standard. So we spent a number of years going deep into high schools, 9th, 10th, 11th grade, identify those students who are interested in becoming physicians, bring them in, evenings, weekends, summer, winter, preparing them, then one extra year for them, local students only, and then finally preparing them. So now we have a pipeline. From the time that I took over, we had one incoming local student in our incoming class. Now 50% of our class are Qatari nationals, 30% more who grew up there, fully 80% of the students are local students. If you see the slide on the right-hand side, it's not only the medical school. What we have also done is to create the ACGME accredited residency programs at our affiliate, even though in terms of governance, we don't control them. Again, using the art of gentle persuasion, we have multiple residency programs which are ACGME accredited. We are bringing back our alumni to populate the local workforce. And finally, on the right extreme is the IGHP, the organization that I shared with you earlier. Oh, by the way, on the extreme left-hand side, you have some of our research publications and numbers. The Z index is quite high, it's about 91. So it's really right there, meets the standards, but the important thing is that you have to think big, then create a mechanism where there's ongoing dialogue, and then prove that you can, yes, create innovations with time, and they can be, I promise you. So I'm finishing here by reminding you, the conclusion is, yes, larger systems, the governments need to be involved, but for the educators, we really need to come up with newer conceptual models, alignment of undergraduate, graduate, and overall continuing professional development models, team-based trainings, and new skills and competencies, which I shared with you, data science, some of the information, social behavioral science, and technology-based solutions, digital platforms, talked about the mixed reality, which is on its way. With all of that, there is no question that I think we will prepare our trainees much better for future than we are doing at this time. So thank you for being here, thank you for listening.
Okay, we have a few minutes for questions, so I can start off. So it's a very innovative program, the Innovations in Global Health Professions Education. So as a starter, how do you plan to normalize the cross-cultural differences, economic differences, educational infrastructure differences, say Korea versus, well, Korea is not a good example because it very mimics the United States, but in other parts of Asia, other parts of Africa, going forward in your innovation?
Yeah. Thank you, Dean Choi. It's a very meaningful question. In fact, the meaningful question. So we have started, so now we know we have the playbook. We have created these alliances with multiple organizations. We will be focusing initially on Asia, certain poorer parts of Asia, and then Africa. And the goal is to really take this American model and prepare people in those areas, I mean, healthcare professionals in those areas, to bring in new competencies in their own training programs. And that's the plan over the next 5 years.
Okay, second question is, technology platform is a big part of your innovations in global health professions education. So let's just take telemedicine, which really was with us pre-pandemic, but has really taken off during the pandemic, and I suspect it's here to stay. So again, in this IGHPE, using telemedicine as a powerful tool, how do you then again implement that in a quality-based standards across the continents?
Yeah, again, a very good question. Thank you. So, I mean, for one example is what we are doing here in the conference, for example, is hybrid, right? So telemedicine, as you said, rightly so, has become part of the mainstream. So this is one of the competencies that we will stress. Definitely, the apps are there, available. They are actually, the last time I checked, there are, believe it or not, 350,000 consumer-oriented apps available in the US. Just during the last year, there were 90,000 new ones. So they are there, the apps are there, the telemedicine is being covered by the insurance in poorer countries. I mean, I know I'm from Pakistan originally. In Pakistan at this time, telemedicine is becoming incredibly popular, and the fees are much less by the specialists. So even people who would not afford the specialist otherwise are getting that kind of help. So this is just one mechanism of technology trying to bridge the gap between the haves and have-nots.
So we have two, so I have a question for one more question. So you ended your slides with the critical role of humanism. So that's a topic that I think is should be independent of economic resources across the continents and countries. So do you think that we need to, as a community, really emphasize humanism even greater in our medical school curriculum, residency curriculum, and physician and continuing medical education? And how do you see that going forward?
So the answer is yes. So how do you do this? I mean, this is honestly, the leaders in different systems have to come in. I was talking earlier about better alignment between undergraduate and graduate medical education, then taking it further to continuing professional development. I think if the humanism training gets started earlier, then it can continue later on. Without humanism, without relationship, there is no healing. So we have to incorporate it. We have to re-emphasize it, basically. No question about it.
Thank you very much.
Thank you.
I think we're on time. So thank you so much, Dean Sheikh. Thank you again. And we'll move on to the next session. Thank you.
It's up to you. Thank you. Thank you, Dean Sheikh, for sharing with us the innovation and expansion of your high-tech, high-touch mission that's shaping the reality of medicine today and in the future. And now, please join Dean Sheikh and Dean Choi as they moderate our closing session, the Leaders Forum.
Good afternoon. Welcome to the session. So today we are really delighted to have a panel discussions among the deans, leaders in their respective medical schools, to just have a discussion among various areas important in medical education. So first, briefly, I would like to introduce our panelists, Dean Chan-Soo Shin, from Dean and Professor of Medicine from Seoul National University School of College of Medicine, and Dr. Dean Shin is an endocrinologist by training. He clinically and education research-wise, he has focused on bone metabolism. He has authored more than 200 papers. He's an associate editor for Journal of Bone and Mineral Research, and has been a leader at SNU for since 2008 in all areas, education, research, and clinical. So Dean Shin, welcome to the panel. Dean Dae-Hyun Liu, from Dean of Yonsei University College of Medicine. Dr. Liu has clinical interests. He's in the Department of Plastic Surgery and Reconstructive Surgery. Clinically, his interest is in craniofacial surgery and breast reconstruction and fat grafts. His research has been used in stem cells in anti-aging and wound healing. And he's an editorial board of European Journal of Plastic Surgery and Journal of Korean Medical Sciences. And he did his research fellowship at Tissue Engineering Laboratory and Wound Healing Laboratory at the Brigham Women's Hospital at Harvard in Boston. So welcome, Dean Liu. And then Dean Sheikh, I introduced him, and so we can get started. So I'm the moderator, and we will discuss critical topics that are facing all of us, whether it's in Qatar, Korea, US, just globally. So we can start with some questions. And the first question is, how has the pandemic affected our medical school education curriculum? And we can get on the residency training, but let me just start off with Dean Shin. How has the impact of COVID-19 been on medical education curriculum and the long-standing effects, and how do you see that going forward? Dean Shin?
Okay. The impact of COVID-19 on medical education is, all over the world, and Korea is the same. And although we thought that the pandemic is a disruption, now we know that it is in some way a catalyst for transformation in medical education. which have been thought for many decades, actually. In Korea and in our School of Medicine, SNU, we changed all the large-scale lecture into VOD, and the professors and students are very satisfied with VOD systems education. The students are satisfied because they can watch the video any time of the day, and they can even fast forward, and they can repeatedly watch the video. So it's more flexible platform. We now understand that. Although the professors are less satisfactory with the system, now they are very accustomed to it and familiar with the system. During the pandemic, although we changed all the education lecture into the VOD, we emphasize that the team-based learning or problem-based learning or lab works in anatomy or physiology should be face-to-face education. We forced it as a mandatory course because in that way we can trace whether the students are going well and they do not get lost. So that is kind of some way you can enforce and make sure that all the students do not lost behind. And next year we are going to move to hybrid way. I mean, more to ensure more students get engaged. In pre-survey, we found that about 30% of students want to attend for face-to-face education rather than just watching the video. So that is the way we need to move forward, because although we are satisfied with the VOD system, this is not the university, what the university is for. I mean, for the educational purpose, we need to move at least blended or hybrid system, and then face-to-face system in the future. Yeah, thank you.
Thank you. To your point of the students wanting to be meeting in person, that was the case in New York. We were in New York last spring. It was a horrific time for all of us, and the administration and my office really shut it down for at least 2 months. But when they came back, especially after the vaccination, the students are saying they really want to continue the in-person curriculum. So I'm glad that you mentioned that here. So Dean Ryu?
I got a similar opinion and experience with Professor Shin. I think I can sum it up with 2 words: digital transformation. So I think the biggest impact of the COVID-19 pandemic on medical education has been an acceleration toward the digital application in teaching. Even before the COVID-19 pandemic, medical education was changing from the large lecture to small lecture, flipped learning or team-based learning, or subgroup discussion. However, this change was slow to implement due to the rigidity among the professors and the preference for the traditional teaching method. Now, professors and students have learned that the online teaching is possible and potentially much more effective and convenient. In addition, these changes have provided the opportunity to break down the barriers between universities and have afforded more free educational opportunity to trainees and the medical students using the digital platform. In clinical field, the necessity of using simulation, such as virtual reality or advanced reality, etc., has also garnered greater interest and as a result of the pandemic. I expect that when the pandemic is over, this change will remain in place. The change in perception toward the online education among professors have been a silver lining of the COVID pandemic. And with this change in perception, the direction of the medical education in the future will likely head toward the blended face-to-face or to non-face-to-face and online education.
Thank you. You focused on digital transformation. So Dean Sheikh is consistent with your previous talk of how critical digital transformation, not just for clinical care, but for medical school education curriculum going forward. So Dean Sheikh?
Sure. Thank you, Dean Choi. Yes, very much agree with you and agree very much with my distinguished colleagues. I mean, in terms of mode of delivery, the change, people adapted because they had to, but they did. Now, I think we have an opportunity now to go beyond that and see how we as faculty, as educators, can look at changing the role of the faculty, become more facilitative, right, as opposed to basically the teacher, the old-fashioned teachers, because now they can watch the videos beforehand, be prepared, and have a more interactive, facilitatory conversation. So that's one of the things we can do. And I think the other thing is, which I touched on earlier, to prepare for digitalization, digital medicine, data science, we really need to prepare our students for new competencies. And because they are coming our way, whether we are ready or not. And I think the faster we get going on the new competencies, the better off we will be. Yeah, so I agree. Thank you.
Thank you very much. So the second topic is I want to talk about mental hygiene among healthcare workers. Even pre-pandemic, we all know the augmentation of the urgency of mental hygiene among healthcare workers during the pandemic. But even pre-pandemic, it's been a huge issue for students and faculty. And so I'd like to start off by asking Dean Shin, in terms of, as leaders, what can we do to implement, to innovate, to support all of the above, how we really help our students reduce the level of stress and a better balance for work-life balance among our medical students?
Okay, it's a very difficult question, and yeah, although the world population, I mean, as a whole, is suffering from COVID pandemic, I mean, medical personnel is not just exception, and actually very vulnerable people, medical healthcare personnel. Their workload is very, very hard, and they are all exhausted now. And in this situation, there is no panacea that you can solve the problem right away, because it is a global problem. The physician or the residency, they cannot solve the problem by themselves. So as a leader in the school or hospital, you need to make sure that you can give some time to rest, or to make sure that the workload can be adequately shared among the personnel. And on top of that, you need to make sure that periodically monitor the workload, so that if some problem happens, you can immediately attend and manage the healthcare personnel in advance. Lastly, you need to advocate the healthcare personnel so that government and the society can make some consensus to provide more resources or even budget for the care of mental health of healthcare personnel. I think there is no single easy way to solve this problem. Yeah.
You certainly emphasize important things as monitoring the workload, resources to help allay their stresses. So very important topics for sure. Dean Ryu?
Actually, mental health on medical students is a very big issue before the pandemic. So I'd like to share our experience for care of mental health. At the Yonsei University College of Medicine made the effort to address the mental health among the students before the pandemic. So in June 2020, we established the Students' Mind Care Center to improve the undergraduate medical students' mental health and well-being. Previously, our school had provided a counseling service to medical students, but we realized that the more proactive and developmental approach for all students is critical. In this context, we have set up the Student Mind Care Center in our students and our student support system to focus on enhancing the resilience and the well-being in addition to counseling. For this purpose, our faculty members at the Department of Medical Education, who is also the psychiatrist, is responsible for the center. And we had added the 2 full-time positions and employed the psychiatrist and clinical psychologist. So we have 3 full-time faculty members in Mind Care Center right now. The Student Mind Care Center has focused on enhancing the self-awareness and building peer network. The center provides the psychological test for personality, well-being, stress, and mental health problem to improve the self-awareness among the students. And also, educational program and workshop on topic such as stress management, time management, functional and dysfunctional perfectionism, and the career choice have been held by the center. And also, medical students in their 2nd or 3rd years have assessed the training program for the developing peer supporters. These students will play a role of mental health supporters among their peers and provide our students with a seamless support. As the pandemic is continue, it is imperative that the students' mental health and the resilience is promoted as an essential part of education, not an extra or hidden curriculum area. And now, let's talk about our staff and faculty. During the pandemic period, it is true that there are little concern and no proper support to address the increase in workload and stress among the professor and staffs. Therefore, from the welfare point of view, it is necessary to improve the support system to faculty and staffs and to implement the policies for well-being and the work balance. As a part of this, I think it is necessary to promote the active participation in professor development program focusing on well-being or work balance, stress management, and the time utilization. And also we need a small group of meeting with the fellow professor to promote the mental health.
Thank you very much. You know, about a year prior to the pandemic, the New York Times, Dean Sheikh, had statistics that in the United States, about a third or up to 40% of the US medical students are seeking professional help, psychiatrists, psychologists, social work, and so forth, compared to 3 decades ago, which was in the single digit. So if you look at this just upslope of this mental health issue, do you think this is all a generational issue? Is it what do you think is causing our medical students to is it the less stigma seeking out for professional help, or what's your thoughts on that?
So first of all,
you're the psychiatrist among all of us.
Well, first of all, I need to compliment you. You were ahead of the curve because you had the workshop in New York, I remember, before the pandemic, identifying that this was a trend which was worrisome. So it's not only medical students. I mean, as you rightfully noted, it's yes, it's a partly generational issue, and there is a long-standing explanation behind it. But let me just get to maybe what we can do and reinforce what my colleagues have already said, that as leaders, we need to intervene in the system to make sure that both in terms of the workload is not excessive, because it has to be realistic, and 2, in terms of students, my feeling is to simplify it, we have to think prevention, intervention, and advocacy. So prevention is you truly have to train the medical students early on from in our program, pre-medical program, self-care. It's not complicated, right? I mean, it's sleep, eating well, moving, and basically having relationship, friendship. Those are 4 things. And that produces resilience and much better mental health over a period of time. It's no different. We have to simplify that, because if we wait till they develop anxiety and depression, then you have to work extra hard. So that's one thing. Second is, if we have to, that's when the intervention comes in. So you have to have connections with the appropriate professionals and resources. And I know in your system you do, and in our systems we do also. But third is the advocacy, which is the ongoing training of faculty, students, and the larger culture in terms of sensitizing them about this, the enormity of this problem. So the stigmatization does not occur. So I think those 3 things need to be done. One last thing about the larger issue, since you asked me, and I'll just say 3 sentences and then I'll stop there on that one, because that's much more complicated. But there's no question that compared to, let's say, last generation, the glue which kept the society together is unfortunately no longer there. The center cannot hold. People are that's why you see it in political polarization also. So this generation, particularly the one which is now going to come up after these medical students, I'm honestly really worried about them, because they grew up, they have been alone together. They have been talking to each other on their iPhones, but they are by themselves. It's next door, they are with their best friends, but not face to face. So by the time they get there, we'll have to prepare with newer models. But the good news is, and I don't want to end on a pessimistic note, I happen to be optimistic. I think we can prepare knowing what is coming our way and creating resources and educational strategies, and we can do it, no question.
No, thank you all. It's a very important topic. The next topic I'd like to go into is, at least in the United States, and I think in many schools in Korea and in Qatar and other places, there's a trend towards non-quantitative evaluation of students. For example, in the US, the preclinical first 2 years, most of the 150 schools are all pass-fail. It used to be, actually, when I was going through, it used to be A, B, C, D, F, and GPAs. And then honors, pass-fail, and now it's just pass-fail. The US National Board exam, step 1 now is pass-fail, starting last year. Step 2, clinical skills, they just got rid of, termination, for many reasons. One was cost. And now the only remaining quantitative scoring is your clinical rotations. And there's a huge movement by our students across the country in the US to terminate clinical rotations grading, because they feel that there's just too much subjectivity and doesn't test the true quality of a medical student. Humanism, collaborative spirit, and different personalities can impress your residents and faculty in different ways. So, I mean, this is the trend now, and I suspect it will continue to go that way. So how do residency directors and faculty or leaders evaluate our students coming out, graduating, and placing them in the respective residency training programs? So, Dean Shen, you want?
Yeah. Although we don't adopt the pass-fail system in SNU College of Medicine yet, we know that the grading system gives great stress to the medical students, all over the world. If you move to pass-fail system, then will it make the medical school easy to finish? I don't think so. If you move to pass-fail system, the students will work hard and study hard. I'm pretty sure. But after the pioneering introduction of pass-fail system in Yonsei University, we have discussed whether we also import the system or not. And at this moment, we haven't decided yet. The reason for this is not because we don't agree on the value of pass-fail system, but the reason is I understand the assessment of the students. The goal of the assessment lies in twice. First is to give feedback to the students. The second is to make sure the student achieve certain level of competency. So if you move A to D grading system to pass or fail, then means you move from judging, just judging and testing, to coaching. And that requires a lot of resources and effort from the faculties. So are we prepared for it? We asked ourselves, and not yet. So we need to prepare in advance for consensus building and capacity building for teaching and coaching ourselves, and then we are going to introduce the pass-fail system.
You point out the very important tenets of the people who feel that we should not go towards pass-fail, because there are some issues with that, and I think those are issues that are very important. Dean Ryu, I am very interested, and I know that the former Dean Yoon initiated the pass-fail, so you must now have some data on how the students feel or how they're doing in terms of pre-pass-fail and what it used to be when they were grading. Dean Ryu?
Actually, we started the PMP system 6 years ago, and the final result is not evaluated yet, but because they grow up to finish the resident program, but their competency is not so low. Actually, at first time, we worried about the learning competency will be decreased if we use the PMP system. Anyway, the competence-oriented medical education spread worldwide. The absolute evaluation to confirm whether or not an individual has achieved the competency is becoming more important. I think it is desirable to have an absolute evaluation that confirms the student's intrinsic motivation and goal achievement along the learning competency. Also, it cannot be said that intellectual academic achievement in medical school is necessarily consistent with the performance in residence. Therefore, it is believed that the competency and the performance among medical school graduates should be evaluated through the portfolio or essay or achievement and letter of recommendation. And that selection of a resident should be made based on this. I do not think it would be correct to say that the evaluation based on qualitative data is not objective. But in our experience, there's some problem. In reality, there are several problems with this. For example, we implement the major improvement of educational curriculum in 2013, and most important goal was the changing in evaluation system. So the relative evaluation changed to the absolute evaluation, and scoring system was changed to PMP system, and the report card been replaced to the portfolio documenting learning competency. One problem is that there is no professors at other medical schools or hospital who understand and properly interpret such information. So it has proven very difficulty for other institutions to assess our students respect to the others. In order to this kind of a system to work, improvement in understanding along all professors and doctors who carried out this sort of evaluation must be achieved.
No, thank you very much. So, you know, the idealistic view among folks who do not favor grading our students is the fact that if you want to be the best doctor you can be, it should not be the motivation for good grades or motivation of whatever, but it should be the motivation that you want to do the best you can be to become the best doctor, and it should not be fueled by the grading system. But in many ways, that's sort of idealistic approach. But you know, this issue will not go away globally. So Dean Sheikh, I do have a question about clinical core rotations evaluations. As you know, in the United States, there's a huge movement by the students. In fact, I'm part of the LCME committee that's looking into that. The tailwind is so strong for many reasons. One, the disparities among Asians versus blacks versus Hispanics and whites, clinical rotations are there. So in this era of disparities, that's a huge issue. Women versus men, there are disparities. And as you know, the honorific AOA society, half the schools have eliminated that. And while Cornell, we still have AOA, but many schools, including Harvard, have gotten rid of AOA. So there is intense pressure going forward. So how do you see, so the critical question is, clinical core rotations are critical in determining what kind of doctor you will be. So if we get rid of, if it's just pass-fail, how will that impact on our ability, again, to make sure that they have the competencies when they graduate? And you, as an expert in your space, do you think that the tenets that grading students in clinical rotations is too subjective because it's too based on too many other variables? So, Dean Sheikh?
Sure. Well, so first of all, I agree with the last, I'll come to that, but your last comment that when students are just graded pass and fail, when they go to another system, people do not understand how good they are, so that's a major shortcoming for us here for our medical students, and I think it will be true for all IMGs. I mean, students who graduate from Korea or other countries who want to do residency in the US, they will be shortchanged by this pass-fail. They already are being, because there is no continuity of history at the residency training director level other than pass-fail. So previously, when the good students had to find a way to demonstrate that they are better than average, or the average US counterparts, they could try to excel. So now that mechanism is gone. So from our point of view, we recognize that this is going to harm our graduates. But leaving that aside, getting to the clinical rotations and assessment, I think, Dean Choi, what you were mentioning was, it seems to me, it is a short-sighted solution to a larger societal problem. The core problems in the society and all the problems that these students bring up, they are real problems, right? I mean, there is disparity, there are all kinds of biases, all of those things are there. But this is not going to take away those problems. I think what this will do is, this is a Band-Aid, but in the long run, it probably will curb quality. That's what I'm worried about. Just listening to you and the rationale behind demanding something like this. I don't know, I'm trying to keep my mind open. It's too early. But that's one of the worries that I have.
Yes. This could be a discussion for hours, and
Yeah.
I know there are many faculty members out there who are very involved in medical school students' education, especially in the clinical rotations. And I can tell you that the major complaint by my medical students is that attending X cannot evaluate me in 4 days. That attending had me for over the weekend, and he or she had some grades. So those are issues. Very few students have a month-long attending because of the schedules that doesn't work. That's the deficiencies of our infrastructure. So the students are saying, you need to, that's your problem. You need to fix a system that a student can work with an attending for a length of time that you really get to know the student. Anyway, we could talk this all day. So thank you for all the comments. The next topic is really at a hospital end, but very important for our medical students and residents. So there's a lot of pressure, I'm sure, in Korea, Qatar, US, of the balance between educational activities versus service activities. And in internal medicine, that's less of an issue, but for the surgical residents, when I say surgery, I just don't mean surgery, but surgery focus like urology, OBGYN, surgical domains. They really do a lot, many activities in the OR that are more service and not educational. And that's a huge issue in the United States. I'm sure it is in Korea. So as leaders of medical schools, and how do you keep the quality of care for our patients at the same time maintaining the quality of education for our medical students and the care of our patients? So, Dean Shin?
Yeah, this is a big problem recently in Korea, especially for, patient right advocate. So many medical school students cannot attend, delivery room because the mother doesn't want to get observed by the medical student. So, but the problem in students are less than that in that of resident. Resident are the trainees, and they're working front line in many teaching hospitals, and they are regarded as two positions, one a physician and second as a trainee. So the leaders of the hospital should take measures, because their working environment is very important for their job satisfaction and also productivity of their residents. So, the role of the leader is very important in this regard. They make sure that the education is the utmost goal of the organization, and to make sure that they periodically monitor their education competency and their progress in department level and as a whole hospital level, and emphasize the role of the hospital as a teaching hospital for all the faculties and all the department head. And there is something which depends on the will and will of the CEO or the CMO of the hospital. Yeah.
No, thank you so much. Those are very important points. Dean Ryu?
In reality, most of the hospital, there is a major focus on value of medical service rather than the educational value. So I think this is common among the both students and professors who read the training. This is because the training hospital lack of the clear identity as an educational institution, and there is no governmental support or compensation to correct the deficit in educational area among the hospital. Therefore, the concept of academic medicine, who recognize that neutering a doctor is a continuous process must be spread all the hospital, and it is necessary to develop a new training model suitable for this. The development of a hospital guideline and more throughout the evolution of educational hospital are needed, and along with the necessary financial support.
Thank you very much. Dean Sheikh?
So I'll just concur with my colleagues, Dean Chin and Dean Ryu's comments. My personal opinion is uninformed, because we don't have a healthcare system as part of our governance system. So we very much actually rely on them dealing with some of these complex issues. So I would say theoretically, I can say there needs to be work-life balance. At the same time, they have to balance the budget. So I'm keeping my mind open. So I can't give you an informed opinion myself.
Yeah, I think there should be a balanced view on this. For example, the students or residents complain that they should not be escorting a patient from the emergency room to the ward or to the radiology suite. Yes, there's no education there, but there's a lot of humanism education. When you have to escort a sick patient on the way to upstairs, there's a lot of patient contact. That's something that you may not think is educational, but it's important for you being a doctor. That's one camp out there, right? On the other side, in the US at least, there's data that if you, it drives the cost of hospitals if you have medical students and residents. But we also have data that improves the metrics of patient outcomes. So I think there's a balance of the two, and hopefully we'll have a happy medium on that going forward. Okay, switching to the next topic is research. That's my favorite topic. So we all know that medical students come to medical school to be a doctor. They are not here to get a PhD and so forth. It's a different career path. But there's an element of what research discipline brings that I think helps you to become a better doctor. That's an opinion, not a fact. So I'm just wondering how important it is for our medical students to have not just exposure, but to have some research time during the 4 to 6 year curriculum, Dean Sheikh. And number two, should it be a requirement that if you graduate with an MD, you should have some competencies in what research entails? You may not pursue a career focused in research, but you should at least understand the disciplines involved in research. So, Dean Shin?
Yeah. I think physicians should take more part in biomedical research. But I know that physicians are less and less involved in biomedical research in US, also in Korea. One of the reasons for this, I think, is they have low chance of exposure and limited opportunity to participate in the research. So I think the early exposure to research is very, very important for more physicians to take part in the biomedical research. And so many schools in US and in Korea also take the gap year or gap semester or research year, which is very good practice in medical school. But whether it should be a requirement for graduation, I don't think it is too premature, I think. But you can give incentives. If you take the research year or gap year for research, then you have some advantage in residence matching or something like that. So giving the incentive is the first, and then you can implement as a requirement later on. Yeah.
Now you bring a good point about exposure early in your career. There's data, very good data, that the earlier the student or resident gets exposed to research, the more likelihood, and there's really a nice graph showing that they will pursue to become either a physician scientist or research being an important part of your career path going forward. So very good point. Dean Ryu?
The research competence is very important in medical school graduate, I think. Such research competence does not simply mean writing a good paper, but recognizing the problems and formulating the hypothesis and objective proving or disproving it to reveal the facts. So in this regard, the research experience in the medical school is very, very important. However, whether the research elective is required may vary depending on the goal of each university's curriculum. For readers, critical thinking, creativity, in-depth learning, scholar experience, etc. are core competence. Therefore, if the university aims to foster the readers as a curriculum goal, it would be recommended to make it a mandatory requirement. However, this will only possible if the faculty and university has a capacity to condition to support this course.
Thank you very much. Dean Sheikh?
Sure. So we've been very fortunate that we got a tradition from our mother campus that almost 100% of our medical students are involved in some kind of research project. However, I support exposure or involvement of students in research no matter where the medical school is for other reasons also. Because, I mean, I grew up in Pakistan. I went to medical school with no exposure to research. And I can tell you from personal experience, I think unless you have been exposed to research, to look at how to define a problem, how to discern the factors underlying that problem, how to create, formulate hypotheses, test them out, look at the data, and then either discard or move on and create another hypothesis. You just believe in magic and heuristics, because that's what human brain is. We all form guesses, and they are usually flawed, and that's been shown again and again and again. So without exposure to research, I think that is a major danger. I know I went through it, lived through it, and I can share that with you. So my bias is you have to expose the students to research.
Yeah, that's our bias. You know, we require 6 months of research for Weill Cornell students. It's called area of concentration. And not only does it improve their resume when they apply to residencies, but I think, number one, I truly believe that you're a better doctor if you have some exposure and has walked the walk in research. I think folks who have done it, they're not only their knowledge of pathogenesis of disease is better, pathophysiology and all the rest. And number two, I think it fosters creativity, which sounds like a buzzword, but it really does. I think medical training and research training uses different parts of your brain. So, and number three, I think it also research is there are a lot of bumps. It's when you're trying to make discoveries, it's not easy, and I think that fosters discipline in your overall training. So anyway, very good discussions. All right, we have time for one last topic. Timing is good. We'll end with technology, which Dean Sheikh told us about in the previous talk. But in terms of the role of technology, we've kind of covered it, but in terms of digital technology, whether it's telemedicine and others, what kind of impact going forward in our medical school education? So Dean Shin?
Yeah. Technology, especially IT, has benefited many fields in our lives, including medicine. From primitive form of consultation over the phone, and then remote glucose monitoring, and now they are using VR for many ways. One of our faculty members opened up a startup that developed a system for CPR education through the AR system. So, I mean, AR and VR is everywhere now. And I think this new kind of technology can be applied to remote learning for operation room or ER. So you feel like we are being there and remotely operate the patient. But there is no limit that can be applied to the medicine in the future. We cannot guess what is the limit of the technology development. But I'd like to focus on what Dean Sheikh said in his talk. There are certain areas that cannot be replaced by the technologies. For example, I mean, it doesn't make sense you teach abdominal palpation using VR or cannulation through AR. It doesn't make sense. And also, if you teach breaking bad news, it is in humanitarian areas. So it uses, facial expression or language processing, something like that. So there is certain areas that face-to-face and humanitarian approach should be reserved and maintained. High touch, what Dean Sheikh said. Yeah, that is my point.
A great point. The humanism that Dean Sheikh mentioned, and you certainly do.
The medicine is changed very rapidly. So the classical medical science is joined the data science, DT, IT. So it changes very much. And in educational area, there will be big change, I think. So within 10 years, the cadaver dissection will be disappeared, and the students exercise with a virtual reality. And nowadays, in resident, we training with virtual reality. For example, in robot surgery, we trained with a virtual space. So it's very effective. So every educational tools will be changed. So I think we have to prepare about that.
Thank you. Dean Sheikh.
Sure. So technology has been with us throughout the history of medicine, and there has never been any question. Physicians have always adopted it with open arms until very recently, where has become so advanced that it scares some people, that we're talking virtual reality, mixed reality, that is too close to human-like qualities. However, if one looks at this, for example, 3 years ago, I was at a conference in Stanford, and they were talking about, well, jokingly, radiologists will be out of jobs. And one of the guys said, no, actually it'll be more enriched radiologists who can use the tools to supplement what they already know, not to supplant themselves. And I think that should be the principle, at least that is for me. There are times then something like mixed reality, when you're going to see your own avatar or holograms, that it will be spooky in many ways. But I think we need to be prepared for that and not run away from it, to find a way to actually use these powerful technologies to our own advantage. Why not?
Okay, so we actually have finished our planned topics, but we do have a chat question that came up. What does the panel think is the biggest threat or danger to healthcare in the 21st century? So Dean Sheikh, we'll start with you.
Well,
what do you think is the biggest threat?
Yeah, I would say ourselves. I think we have touched on culture, we have touched on technology, we have touched on training. To me, a common thread all along is the change is coming, and it's very rapid, and we are not fully prepared for it. And my fear is that we might be coming up with partial, short-term solutions for this problem and that problem, and they are not disparate problems. This is a common underlying theme and a thread that technology is changing, for example, very fast. Society is changing very fast. We better sit down, some wise heads, and come up with longer-term solutions to deal with it. It is here. So that'd be my take-home lesson.
Sure, thank you. Dean Ryu, you want to?
It's a very difficult question. I think the loss of humanity is most big threat of the healthcare, because the technology is advanced more and more, and that procedure, the humanity, it can be disappeared or something. So we have to reinforce the education of humanity to our students. I think so.
Thank you. Dean Shin.
I need to talk in the other way. I mean, not the conceptual level, but in practice. I think we can conquer cancer, or even in bone marrow metabolism using DNA repair. But now the new threat is emerging infectious diseases. You can understand in this COVID-19 pandemic. So 21st century, I think the new emerging infectious disease will be a great threat to all mankind.
Sure, yeah, especially the public health issues. Well, that concludes our panel group. I just want to say thank you all. We have discussed, I think, 6 of the most difficult and controversial areas, which is so important. So I just want to say that, we're in a great profession, noble profession. We take care of human beings. We heal the sick. And these 6 topics we discussed really is a way to how to get it better. And these are issues facing our students and our trainees and our faculty. So terrific discussion. Thank you all, deans, and thank you again. Thank you.
Thank you.
Thank you so much, Dean Choi, and also for the participation in this very vivid discussion amongst our leaders today. On behalf of the Executive Committee of CAMA, I would like to thank all of you for your participation and for engaging in this community. We welcome you tomorrow morning, bright and early here in Korea, to another discussion and to other sessions. So thank you very much, and we look forward to seeing you tomorrow. Good night.